Assalamu alaikum everyone. I hope you guys are all doing well. Um, First of all, Eid Mubarak, kul aam wa antum bkhair. Inshallah you're all doing well. I know you have your exam in a few days. Inshallah it goes well. طيب. First and foremost, I am a bit sick. I apologize if my throat isn't as clear and I keep coughing in this session. But anyways, Allah salamkum. Inshallah for today, this will be the last part of this crash course, part 3. This will be by far my favorite part of GI, which is the hepatopancreato-biliary system. We're going to conclude everything about these three organs, the liver, the gallbladder, and the biliary tree, and inshallah the pancreas from this session. There will be 2 extra slides that I added, which is basically stuff that I found very important, although it wasn't directly mentioned in your slides. And one thing that I forgot from radiology to include from the previous sessions. We'll check it at the end. Tamam? So let's start. Again, I need you guys to be interactive. I'll explain concepts in the beginning, but then I'll ask you guys, what's this pathology, the treatment, and so on. Let's start with the liver anatomy. In terms of the gross anatomy, there isn't anything that's important for you guys to remember for the gross anatomy of the liver. But for the microscopic and histology, it's very, very important. So the first thing we're going to look at is the functional zones of the liver. Tamam? Now, for the functional zones of the liver, firstly, we'll talk about the lobule. So the lobule is formed by the portal triad and the central veins. So the portal triad is 3 different structures. Number 1 is the portal vein, which will drain the entire GI, all the nutrients and everything that goes to the liver. Right, then the second vessel is the hepatic artery, okay? So the hepatic artery is carrying systemic oxygenated blood from the celiac trunk, okay? The third thing is the bile duct. The bile duct will carry the bile from the hepatocytes that's been synthesized, and it goes into the biliary tract and then to the duodenum for lipid digestion and absorption. So if we put 6 of these together and form it into this shape, this is what we call a lobule. At the center of the lobule is the central vein, which will go into the systemic venous circulation, into the hepatic vein, and then that goes to the heart through the inferior vena cava. Now, we can divide this lobe into 3 different zones, which is very, very high yield and important. The first zone, which is the periportal, it's next to the portal triad and the portal tract, is zone 1, which is this zone over here or this zone over here. Okay, this is zone 1. Zone 1 will be right next to the portal vein and the hepatic artery. So zone 1 will have the highest amount of oxygen, okay, because it's right next to the arterial supply. Tamam. Then you go to the zone 2, it'll be less oxygenated, okay? Then zone 3 will have the least oxygen from the 3 zones. So because of this, which of the 3 zones is most susceptible to ischemia? Excellent, good. Zone 3, because it has the least amount of oxygen. This is very important, okay? Most of the oxygen will be periportal. It will diffuse, it will supply this area. Lesser amount will be in this zone, the intermediate zone, and the least will be in zone 3, okay? So this is the most prone to oxygenation. Another important function is the cytochrome enzymes. Which of the 3 zones have the highest amount of cytochrome enzymes? Excellent, good. Zone 3, again, this is very important. So, because it has the cytochrome enzymes, it's better able to metabolize toxins. So from the 3 zones, which zone is more susceptible to toxin damage? Excellent, good. Zone 1, okay? This is what's high yield. Other than that, obviously from the portal vein and the hepatic artery, you'll have the highest amount of oxygen, as we mentioned. The gluconeogenesis. Gluconeogenesis, you're producing glucose. where do you want this glucose to go? To the systemic circulation, okay? So obviously, the highest amount of gluconeogenesis will be here, and it will go downwards, okay? Because where are you going to get the byproducts or the substrates to produce glucose? From protein digestion, from lipids, and as well, okay? So from the portal tract, you'll get the highest amount of substrates. It's going to produce glucose, and you want this glucose to go into the central vein because that's where you have it, or that's where it will go to the systemic circulation. Then you have beta oxidation, which is to break down fatty acids. Again, it will be highest over here because later on you want it to all dump into the circulation. As for the rest of it, you have glycolysis, which is going to be over here, and that's more in zone 3. Ketogenesis more in zone 3. Triglycerides synthesis is more in zone 3, and so on, okay? Then we come to this figure. Now, the portal vein and the hepatic artery will drain into these structures called sinusoids, okay? These sinusoids will later on drain into the central hepatic vein, which will go to the systemic circulation. Around the sinusoids is very important. If you have fibrosis around the sinusoids, this can compress on the sinusoids, okay, because of the fibrosis. If you have compression of the sinusoids, this will cause a lot of pressure to build up before the area of obstruction or the area of fibrosis, which is going to go into the portal circulation, which can cause or is one of the pathogenesis of portal hypertension. It's because of the fibrosis that happens in cirrhosis. Okay, so you have fibrosis that happens around the sinusoids that causes buildup of volume before this area of fibrosis, which will lead to hypertension. Other than that, you have the lymphatic drainage of the liver, which is through the space of disc that will go into the lymphatic circulation. Important thing about the space of disc is that it can get overwhelmed, okay? Because of portal hypertension, it can get very, very overwhelmed. When it gets overwhelmed, the remaining lymphatic drainage or the remaining fluid will ignore the space of disc because it's already at full capacity. It will go between hepatocytes and it will diffuse into the abdominal cavity, which is one of the causes of ascites. Okay, so this is the basics of the liver and how it relates to the pathologies in terms of cirrhosis and portal hypertension and ascites. Okay. Now, this is another diagram explaining it, but I want you guys to know the functions of two important cells in the liver. The first cell is the Kupffer cell. The Kupffer cell has what function? You guys tell me. Immunity. Good. It acts like a macrophage, exactly. So it has phagocytosis functions, okay? It's immune cell. Now you have stellate cells. Another name for stellate cells is ITO cells, ITO cells, okay? ITO cells or stellate cells are important in mediating fibrosis, okay? This is the main cell responsible for fibrosis seen in cirrhosis, okay? Remember this important cell, okay? Because you might get a question about someone with cirrhosis and they ask you which cell is mediating the fibrosis. It's stellate cells or ITO cells, okay? So, now in the liver, you have normal type 4 collagen. And if you guys remember, is that the basement membranes of many different cells, of most cells, are lined by type 4 collagen basement membrane, okay? So this is the normal basement membrane or the normal type 4 collagen in the liver, okay? This in cirrhosis and fibrosis can change into two other types of collagen that we'll get to, and I'll ask you guys about this later. We can stain this by using reticulin stain, and it shows it's the type of collagen and the abundancy of the collagen, which is this brown bits around the hepatocytes. Okay. Now, I'll ask you guys this. When you are assessing the hepatopancreatobiliary system, what is the first line imaging modality that you use? First imaging modality that you use. Excellent, good. The first line imaging modality that you use is ultrasound. It's the safest, it's the easiest to use. You can do it on the spot, and it can show you most pathologies, okay? In terms of the liver, it can show you a lot of pathologies. However, there are certain things you want to do a CT scan for. We'll look into the ultrasound first. Now, this is the right side of the liver, and this is the left side, okay? So this is the right lobe, and this is the left lobe. This line over here, the bright line, let's go back to first year GIT anatomy. What is this bright line? Do you guys know? Good, the diaphragm, okay? This is the diaphragm. I remember one of the batches got this. So here you go. This is the diaphragm, okay? Now remember this. Then you have this, which is the hepatic arteries. You have the right hepatic artery, middle, and then the left hepatic artery. So now in the liver, usually we'll have another structure with it, which is either the kidney, you look at the kidney, or you compare it to the spleen. Why do you want to do this? Is you want to see how echogenic, which is how bright the liver is. Why do you want to do that? Is you might have someone with fatty liver, okay? Fat in ultrasound is going to appear bright, okay? So if the liver appears bright compared to the spleen or the kidney, this is a sign of fatty liver, okay? Another pathology that you can see in ultrasound is a cyst, okay? A cyst will be anechoic, it'll just be black, okay? And that's pretty much, and with posterior acoustic enhancement, which is brightness right behind the cyst, okay? So that's basically ultrasound liver. Then you have this, which is the most important thing about the liver imaging, which is CT scan. CT scan, you preferably will do it with contrast, okay? Why so? Is because you want to differentiate the liver masses that you can see, okay? Let's look at it without contrast, which is this image. How can I know that this doesn't have contrast? You have to look at the aorta. The aorta in this image is isodense compared to the rest of the structures. It's the same density. It's the same brightness, okay? So this is how I can say, okay, this patient did not have any contrast given to them, okay? Then you want to identify the structures. So this over here is the liver. This is the right lobe of the liver. And this is the gallbladder over here. Now this liver is nodular, it's shrunken a bit. So you might say this is what pathology? If it's nodular and shrunken. Cirrhosis, good. We'll get to this later in more detail. But yes, okay, cirrhosis. Now, cirrhosis can lead to complications. One of them is cancer, okay? Now, if you have a suspected patient with cancer, you need to do contrast, okay? Contrast enhanced CT. Now, when you do contrast CT, you have three phases that you need to look into. First one is the no contrast phase, which is not going to show you much. Arterial phase, then the venous phase or the delayed phase. We don't really look at portal as much. It's not too important to know, okay? So, how do I know this is arterial phase? Is look at the aorta. This, okay? The aorta is very hyperdense. It's very bright, okay? Compared to the rest of the structures. So this is how I can say, okay, the contrast is in the arterial system. It's in the aorta. Then we look into here. You see this mass over here in the liver? It's enhancing with contrast, okay? That means that this mass has arterial blood supply. This is what this means, okay? That the blood is going to this mass and it's enhancing. It's hyperdense compared to the surrounding structure, the surrounding liver. So this is a mass. The important thing is, how does this mass enhance? Is it all enhancing, which is in this case, yes, or is there enhancement from the periphery to the center? In this case, it's all enhancing at once, okay? We'll get to the other example later, which is diagnostic for another type of tumor, okay? After the arterial phase, most of the contrast is going to go to the venous circulation. So this is what we call a delayed phase or venous phase, where you can see the aorta, it's no longer hyperdense anymore. It's going to go into the venous circulation. In this case, here you want to see, is there a washout of the contrast, being that the contrast from this mass that was here enhancing go away completely? In this case, yes, it's no longer there anymore, because this mass now, it's hypodense compared to the rest of the liver. So this is what I call contrast washout. This is diagnostic for hepatocellular carcinoma on imaging, okay? It fully enhances an arterial phase. Delayed phase, there is venous or delayed washout, okay? Again, this is hepatocellular carcinoma. Do you guys understand the phases in CT? Because this is very important. Good. Tamam. Now the next thing is liver function. There's many functions of the liver. Liver does a bunch of stuff, okay? By far, it does a lot, okay? We'll talk about some of the important functions. First of all, it metabolizes and detoxifies drugs, alcohol, hormones, which is very important. Why is this all important? Number one is with alcohol and drugs, usually when someone has chronic liver disease, you do not want to give them drugs that are hepatotoxic. So such as antibiotics, NSAIDs, and so on. You want to reduce the amount of drugs that are hepatotoxic or metabolized by the liver, okay? The other thing is steroidal hormones. The most important hormone that I want you guys to remember is estrogen, okay? So estrogen is metabolized and broken down in the liver. If you have a patient with cirrhosis or with chronic liver disease, they will have decreased metabolism of estrogen, leading to high estrogen levels, which leads to, in males, very importantly, gynecomastia. Good. So it leads to gynecomastia. That's one of the signs of cirrhosis, of chronic liver disease. Other than that, it can cause also these red spots on the chest, which is called spider angiomas. It can cause decreased hair, especially in the chest area. And that's pretty much like the most important signs of high estrogen in liver disease, okay? Obviously, it's regulated, or the liver function, it's involved in metabolism, obviously. Then you have all of these proteins that are involved in the liver. Very importantly, is that it's involved in clotting factors. This is the site of synthesis of clotting factors, okay? Also, you have an important vitamin that is basically activated in the liver, which is vitamin K. Why is vitamin K important? It's because vitamin K is important for the vitamin K dependent clotting factors, which is 2, 7, 9, and 10. So if you have a patient with chronic liver disease or with cirrhosis, they will have a deficiency of clotting factors and deficiency of the vitamin K dependent factors, okay? So with this, what lab value will be elevated in patients with liver disease because of this function? PT, excellent. The most important clotting factor in this case would be factor 7. Okay, that's why PT is the one that's elevated. Okay. Then you have also the liver synthesizes thrombopoietin. Thrombopoietin will activate what, or will cause an increased synthesis of what blood cell? Thrombopoietin, platelets, good. So because of this, you'll have decrease in platelets in liver disease. Okay. Here's another reason why you have decreased platelets, which we'll get to that reason, I think, in the next slide or in the next few slides. Then globulins for immunofunction. So in patients with liver disease, they have immunodeficiency. Albumin, very important, synthesized in the liver. It's one of the liver function tests that we look at. And this is important because it can lead to low oncotic pressure, which leads to edema. Okay. Now, this is very important over here, is this. The liver is the main site for ammonia metabolism. Okay. It converts ammonia to urea, which gets secreted in the kidney. Okay. So, in patients with liver disease, they have hyperammonemia. Okay. Which leads to what manifestation in liver disease? What can that cause? Hepatic encephalopathy, which presents as confusion, altered mental status, and what's one physical sign? What is this? Ataraxis. Good. Tamam. We'll get to this later again. All of this again. Tamam. Then you have all of these vitamins, the fat-soluble enzyme, fat-soluble vitamin, sorry, gets stored in the liver alongside B12 as well. As well as all the, the nutrients such as carbohydrates, protein, lipid metabolism, okay? The other function that's important is involve the hemoglobin breakdown and bilirubin, okay? Now, before I start with the slide, is bilirubin. There's two types that you guys need to know, obviously. So bilirubin, there's unconjugated and conjugated, okay? Unconjugated, another name for it is indirect bilirubin. Direct bilirubin is the conjugated one. Now, how does it get conjugated? Where does bilirubin come from? Let's start from this. Hemoglobin in the spleen gets phagocytosed by macrophages. Through multiple steps, it gets converted to unconjugated bilirubin. Okay, it gets converted to unconjugated bilirubin. This bilirubin will go to the hepatocytes. In the liver, it gets conjugated by an enzyme that is called UDP glucuronidase transferase. UDP glucuronidase transferase. This enzyme is very important, okay? Conjugates bilirubin. This conjugated bilirubin then will go into the bile and then will go into the intestines for lipid metabolism, okay? Which part of the intestines will it go into? The second part of the duodenum, okay? So now, in the stool or in the bowel, it gets converted into, it gets deconjugated in the bowel, okay, by bacteria, okay? It gets deconjugated. And it forms urobilinogen. Urobilinogen in the bowel gets converted to stercobilin, which gets excreted. This is what gives the stool the black or the darker color of stool, okay? Now most of the urobilin in the terminal ileum gets circulated back into the liver through the enterohepatic circulation. A small part of urobilinogen gets converted to urobilin and gets secreted into the kidneys, okay, into the urine. Tama. Now, there are three pathologies that can happen here. We divide into three. That causes hyperbilirubinemia, high bilirubin. Prehepatic, intrahepatic, which is all over here, and posthepatic. Tamam. Let's start intrahepatic. What causes hyperbilirubinemia is increased breakdown of hemoglobin. Give me two causes of increased breakdown of hemoglobin or heme breakdown. Hemolytic anemia, hemolysis, good. Give me two types of hemolytic anemias. Give me two types. Good. G6PD, sickle cell anemia, sickle cell disease, autoimmune hemolytic anemia, paroxysmal nocturnal hemoglobinuria. There's many, okay? Anyways, what does this cause? Increased breakdown of heme that then converts it to bilirubin. This bilirubin, is it unconjugated or conjugated? Unconjugated, good. Now, a lot of this will go to the liver to get conjugated, but it overwhelms the liver. It can't all get conjugated, so it's going to be unconjugated hyperbilirubinemia, okay? So most patients with hemolytic anemias will present with jaundice, okay? Now, intrahepatic is due to liver disease. Cirrhosis patients will present with jaundice. Liver disease patients will present with jaundice. Viral hepatitis patients will present with jaundice, so on and so forth. Why? Is because the liver cells, the hepatocytes, won't be able to conjugate the bilirubin, okay, anymore because of the enzyme defect. Other than that, you have hereditary causes of hyperbilirubinemia due to defects of this enzyme, the UDP glucuronidase. There's one that's very mild, and there's one that's severe. What is the mild decrease in UDP glucuronidase? What disease is this? Gilbert syndrome. Perfect. Severe, almost no enzyme available. What is that one? Kringler-Najjar, okay, syndrome. Dubin-Johnson is direct hyperbilirubinemia, okay? We'll get to these later, okay? But it's Kringler-Najjar syndrome, okay? So this will be an elevation in mostly unconjugated indirect hyperbilirubinemia, okay? Then if you have failure of bilirubin to go into the bile, okay, or an obstruction of the bile duct, okay, this will cause conjugated or unconjugated hyperbilirubinemia, post-hepatic obstruction. Conjugated hyperbilirubinemia, perfect. Causes of this, there's many, and we'll get to this in the obstructive jaundice causes later on, okay? But anything post-hepatic causes conjugated hyperbilirubinemia or direct hyperbilirubinemia. Now, very importantly is lab markers, and this is important for you guys to understand from now, okay? So, for lab markers, for liver markers, you have two different types. Firstly is liver enzymes. The second is liver function tests, okay? Hepatocellular liver enzymes, which is from the hepatocytes, there's two, ALT and AST, okay? Now, in all patients with liver diseases, both ALT and AST will go up. Which one will be higher, ALT or AST in most liver diseases? ALT, good. In alcoholic liver disease, which one would be higher? AST, excellent, good. This is important, very important, okay? Good, 2-to-1 ratio. Now, there's one more thing about ALT and AST I want to talk about before we go into alkaline phosphatase, and there's stuff about that as well, is in viral hepatitis. I do not know if you guys were told this, but this is kind of important to look at, is usually these two markers, ALT and AST, will be in the thousands. It will be very high, okay, in a viral hepatitis, okay? Not all the time, but if you see it with a patient who had a history of a needle stick injury, then you know that this is viral hepatitis, and we'll get to that later, okay? Now, markers for cholestasis, which is biliary tract stasis, bile stasis, or biliary diseases in the bile ducts, you have two, alkaline phosphatase and gamma GT. Which one is more sensitive and specific from these two for bile duct diseases? It's gamma GT. Why gamma GT? Alkaline phosphatase, you can detect it in bone diseases. Exactly. Gamma GT, it's highly sensitive, okay, for biliary tract. Usually this will be elevated. Dr. Abel Khail mentions this, which is kind of important. It does have high sensitivity, but low specificity. This is to what type of biliary disease I believe he's talking about, because it doesn't differentiate what biliary disease he has, okay? As anyways, it's elevated in biliary diseases, okay? Now, gamma GT is also elevated with alcoholic use. You can monitor alcoholic patients with gamma GT. Now, very important is how do you know this patient? Because usually there's overlap between ALT, AST, and alkaline phosphatase. There is one number or one ratio that you need to look into, which is called the R ratio. The R ratio is looking at ALT over alkaline phosphatase, okay? Obviously, alkaline phosphatase, ALT will be elevated more than alkaline phosphatase. However, if you have a super high alkaline phosphatase, this will change the ratio around, okay? So the R ratio, there's two numbers you need to look at. Number one, if it's greater than 5, okay? And the other one, if it's less than 2, okay? So if it's greater than 5, which means ALT is greater than, way higher than AST, does this mean hepatic damage or cholestatic? Hepatocellular or cholestatic? If ALT, good, hepatic. If it's less than 2, which means alkaline phosphatase is so high, is it cholestatic or hepatic? Cholestatic. Good. This is very important. Okay. Tamam. Then the functional liver function tests. So yeah, bilirubin, as I said, it's elevated in many liver disease. You can characterize it by prehepatic, intrahepatic, posthepatic. We talked about this already. Okay. Albumin, as I said, that's synthesized by the liver. So in liver diseases, it's decreased. Okay. PT is increased. As I said, why is because of clotting factors and because of vitamin K, okay? Dependent factors. The last thing is platelets, and as I said, it's decreased first because of thrombopoietin and there's sequestration. Because of portal hypertension, you have sequestration in the spleen, okay? Mostly in the spleen. You also have liver sequestration as well, okay? So that's basically the liver function tests, okay? Are the basics clear with you guys? We took a while, but it basically summarizes a lot of this lecture. Okay. Tamam. Let us go into viral hepatitis. This is very important, and you'll get questions and questions and questions on this. Okay. So you have 5 viruses that are involved in viral hepatitis: A, B, C, D, and E. Okay. Let's talk about them one by one. There is a table, but let's go without the table, then we'll look at the table. Let's start with hepatitis A. Hepatitis A is what type of virus? Is it DNA or an RNA virus? RNA. It's a single-stranded positive sense RNA, okay? Does it have an envelope or no envelope? No envelope, good. How is it transmitted? Fecal oral, good. Usually, in the case they will give it to you, is that this patient traveled to an endemic country and drank water. It's usually from the water that it's transmitted, okay? Then you drink it, fecal oral, and it causes hepatitis. Is the hepatitis infection in this case, it's acute, okay? It does not lead to chronic infection. Does it resolve and have good prognosis? Yes or no? Yes, this is very important. Hepatitis A is self-limiting. It will go away on its own. And usually patients recover well, okay, afterwards, okay? Now, does it have a vaccine? Yes or no, if you guys know. It does have a vaccine, okay? Hepatitis A has a vaccine. I'll get to the ones that has a vaccine, which is A and another one that we'll get to later. Now, similar to hepatitis A, to diagnose it, there's IgM and IgG. Okay. IgM antibodies to hepatitis A is going to tell you that this patient currently has hepatitis. IgG just tells you that the patient had hepatitis somewhere in their life. Does not tell you that the patient has it now. Okay. Or if the patient had vaccine, they'll have IgG antibodies. Okay. Tamam. The counterpart, very similar to it, is hepatitis E. Again, hepatitis E, what type of virus is it? RNA or DNA? RNA. Again, it's a single-stranded positive sense RNA that has no envelope. It's the same. Tell you. The family of viruses, it's different. However, it's the same type of virus. Okay. Anyways, this one is again fecal oral. The most important is what group of patients will have severe hepatitis. Exactly. Pregnant females. In pregnant females, they will typically have fulminant severe hepatitis with hepatitis E. Usually it's self-limiting. However, pregnant women have fulminant hepatitis. Okay. In the case, they'll give it to you as a pregnant woman. Okay. They will have to put it. Severe symptoms of hepatitis. It might be in the case that they pass away or they die because of it, or require liver transplant, and they ask you which type of viral hepatitis. It's hepatitis E. Okay. Now we're done with this. Let's go to the next one, which is hepatitis B. Okay. Now, hepatitis B, what type of virus is it? DNA or RNA? DNA. It's a very weird DNA one because usually it's double-stranded. This one is partially double-stranded, okay? You don't need to know how it's replicated and all that stuff. It's not too important. But anyways, it's a circular DNA virus, okay? Partially double-stranded. Anyways, how is this transmitted? 3 ways that this one is transmitted. IV, which is parenteral through blood. What's the second way? Sexual, good. And one more. Bodily fluids, good. One more. Exactly. Transplacentally to the baby. Good. This one is very important in terms of how you diagnose it, the serology, and we'll have serology, okay, practicing in the next slides. But anyways, this one can cause acute hepatitis and then has a very long incubation period, which is how long till you actually get the acute hepatitis. Then gets acute hepatitis, then it usually resolves, okay? However, this can progress into hepatocellular carcinoma, can progress into chronic hepatitis, or resolve completely, okay? So that's about it for hepatitis B. An important one with hepatitis B is hepatitis D. Again, hepatitis D is what type of virus? DNA or RNA? RNA. This one is the only one that's single-stranded negative sense, okay? Negative single-stranded RNA. Okay. This one, again, it's a similar route of transmission as hepatitis B. What's very important is this one does not have a surface antigen. So it requires what virus? It needs what virus? Hepatitis B, good. What in hepatitis B does it require? What does the hepatitis B give it? Surface antigen, good. So I can go into the hepatocytes, okay? Now you have two presentations with patients with hepatitis D. Either a co-infection, which is basically a patient with hepatitis B also has hepatitis D, or a super infection, which is after the patient has hepatitis B, they have hepatitis D. Which one is worse from the two? Co-infection or super infection? Super infection. Good. Tamam. Last one is hepatitis C. Now, hepatitis C is what type of virus? RNA or DNA? RNA, positive single-stranded RNA virus. How is this primarily transmitted? IV, okay, parenteral, okay, through basically needle-stick injuries usually. This one causes chronic liver disease, which progresses to cirrhosis, which progresses to hepatocellular carcinoma. Good. This one is very important, okay, in terms of how it progresses to HCC. This is the table from first aid. We covered all of it already, everything on this. Now, liver biopsy, the three that you need to remember are these three, okay? Hepatitis A, there's no picture. However, you can see councilman bodies. Councilman bodies are non-specific signs, okay? You can see it in many causes of hepatitis. If you remember from heme, yellow fever virus, you can see councilman bodies, okay? Hepatitis B, you can see councilman bodies. Hepatitis A, you can see councilman bodies. And hepatocyte swelling. The more important two, yes, and apoptotic cells, I think, as well. Yeah. What's it called? Hepatitis B, a very important sign is this ground glass appearance, and we'll get to that later, with the councilman bodies, with the balloon degeneration that we're going to look into. And lastly is hepatitis C, which will have lymphoid aggregation, which we'll look into, with steatosis. Again, we'll see this in a slide. Now, in terms of diagnosing hepatitis, you have to look into serology. Now, for all the types of hepatitis, except hepatitis B, it's not too important, okay? The most important one is hepatitis B. You need to know the different antigens and antibody. When are they elevated? When are they positive? When are they negative? You need to know them, all of them, okay? Let's look into this. Hepatitis B has 3 antigens with its associated antibodies, 3. First one is on the external. It's a surface protein, which is the surface antigen, okay? Then you have the envelope, which is this one over here. What is this? The envelope antigen. Then the core antigen. These are the 3 antigens. With time, they will develop antibodies against these antigens, okay? So you have core antibody, envelope antibody, surface antibodies, okay? Now, let's look into each of these. The first one is the hepatitis B surface antigen. This one is the best marker for current hepatitis infection, okay? The patient has hepatitis B right now. Which antibody you want to do, or antigen, is hepatitis B surface antigen. It tells you right now the patient has hepatitis. Whether the patient has chronic or acute, it will differ in other antibodies and antigens. This one just tells you this patient right now has hepatitis. Whether it's a chronic or acute, we don't know yet, okay? Right now has the infection, okay? If the patient recovers or takes a vaccine, which is the other one that has a vaccine, other than hepatitis A, hepatitis B has a vaccine, then you'll have antibodies that are produced against the surface antigen. Either we give the antibodies through the vaccine, you produce the antibodies, or this patient had an infection and you have production of these antibodies. So if you see anti-surface antibodies or surface hepatitis B surface antibodies, this indicates that the patient either recovered or has previous immunity due to vaccine. Okay. The next one is core antigen. Not important in terms of knowing if the patient has infection or what type of infection. The more important is the antibody associated with the core antigen. So the hepatitis B core antibody has 2 types, IgM and IgG. The acute one is IgM, obviously. The first antibodies that produce is IgM. Later on, it turns into IgG. Okay, later. That's a key term. So the first one is IgM. IgM is the best one to tell you that this one has an acute infection from these 2. So How do I know that this patient has an acute infection? Firstly, how do I know if the patient has an infection right now? You see hepatitis B surface antigen. It's positive. Okay, does a patient have acute or chronic? If IgM is elevated for core antibody, then it's acute. If it's IgG, then this is chronic. Okay. Now, other than that, an important part of the IgM core antibody is that if it's the only thing that's elevated, it indicates something called the window period. What is this window period? It's basically this. After the patient has acute hepatitis, okay, and will go into recovery, there is a window period until the antibody for the surface antibody gets produced, okay? In this case, there will be nothing that's elevated except the IgM, the hepatitis B antibodies, okay? If this is the only thing that's elevated. Hepatitis B envelope antigen or antibody, the most important thing about this is its role in infectivity. If you have high amounts of envelope, I don't get your question. It depends, يعني if لا, you check. If it's chronic, you check for IgG. Because if chronic, then IgM won't be elevated. If it's more than 6 weeks, the patient still has hepatitis, you check for IgG for core. No, it's not the same. I'm not sure actually what that is, Saha. I've never heard of that. That's basically the window is when the patient has acute one or the infection. Later on will develop into recovery. They need to produce antibodies specifically to the surface antigen, okay? That time that it takes for it to produce the antibodies after the patient has the infection is what we call the window period. In this window period, the patient does not have hepatitis anymore. None of the antigens and antibodies will be elevated except one, which is the core antibody. That's the only thing you need to know about the window period. It's not too important. Last year, Dr. Abel Khair literally told us it as a joke, like, when is the only time we see this elevated? But then he was like, you don't need to know. So I don't think you guys will be quizzed on this or tested on this, okay? That's for you guys to know. Now, as I said, the envelope antigen, this indicates infectivity. So this means that the patient might transmit the disease, okay? A very high chance of transmitting the disease. So that's it. Well, we're going to practice this in a bit, and hopefully by then it'll be fully clear, okay? Now we'll look into histology. What does this patient have? Hepatitis B infection, good. What is the sign? Ground glass, good. What is this? Cancer in body, good. How about this? Good. This is balloon degeneration. Good. Hepatitis B. Now we'll practice um, the serology. Let's look at this one by one. This one, the first one is not important, okay? But as I said, let me see if you guys can get this. But you're not gonna get tested on this first one. If the only thing elevated is surface antigen, what does this patient have? Infection. This means that the patient has current infection. However, anti-hepatitis B core antibody is not elevated. So this is what we call incubation. Okay, this patient is he has infection right now, but he's about to get the symptoms. Okay. Again, you won't be tested on this first one. Okay, this was just from first aid, and I took the table as is. Now, the ones that you will get tested on, these next few. Okay. This first one, his surface antigen is elevated with IgM core antibody. What does he have? Acute infection, and excellent. As one of you mentioned, it's highly infective. Why? Is because of the envelope antigen. Okay, the E antigen. E antigen means that it's highly infective. Okay, it's an acute infection that's highly infective. Good. This patient who only has elevated IgM core antibody window period. Good. This patient who has anti-surface antibodies with IgG anti-core antibodies recovered. Good. Okay. Good. Then this patient who has surface antigen with IgG core antibodies, and he has elevated E antigen. Good. Chronic, highly infective. Good. This one has no envelope, so this means is it highly infective or low? Low infective. Good. Now this patient over here only has positive in hepatitis B surface antibodies, immunized, vaccine. Good. Is the serology clear? Then hepatitis B. Good. You guys, if there's anything that you'll be tested on, it's either in the histology from the previous slide or this. Okay. You'll get a patient who will have, they'll list out the positive antibodies and antigens, and they'll ask you what type of infection that they have. Okay. This is what you'll get. In terms of pharma, in my opinion, out of all drugs like that I've studied, this one and HIV drugs are the worst. I don't like them. Okay. For hepatitis B, C, and HIV drugs, I really don't like them. Okay, which is the antivirals. Okay. So you have mainly two classes of drugs that you can use against hepatitis B. You have interferons, and then you have the nucleoside or nucleotide analogs. Okay. So the interferon, if you guys know in immunology, you have regularly interferons that are produced, which is usually interferon alpha, beta, gamma. You want to use primarily interferon alpha, which is targeted towards viruses. And interferon beta also has viral activity, okay? So what do interferons do when you give it? It activates JAK-STAT, okay? Which has antiviral activity, has cytotoxic damage to viral cells, okay? So it's used in mainly hepatitis B. The main side effects that you need, the most common side effect of interferon is what? Most common side effect? Most common. Not the most important. Flu-like symptoms, fever, good. This is the most common side effect. Very important side effect, however, that the patient might have is the dose-limiting toxicity, which is a myelosuppression or myelotoxicity, bone marrow toxicity. Okay, so that's pretty much that. There's another form in interferons called pegylated interferon. This has a better, it increases the bioavailability of the drug, and it's well tolerated. There's less symptoms. Okay, that's what pegylated is. Don't worry about what's first line, second line, and so on. Your lecture did not mention them. Okay, what's first line, second line? This is an old table, I believe. The only thing that did mention it is for this, and I'll get to what about this. Then you have nucleoside analogs, which is hepatitis B. It's a DNA virus, so it will need to go through DNA replication. The main enzyme that's going to inhibit for all of these drugs is DNA polymerase. Okay, so for the DNA polymerase inhibitor, so you have the nucleoside analogs, which is the same as HIV ones, if you remember. So you have tenofovir, lamivudine, and adifovir. These are the three you need to know. Tenofovir and adifovir are similar. Lamivudine is a bit different, okay? in terms of it's a cytosine analog. Tenofovir and adenofovir are adenosine analogs. Okay. Anyways, tenofovir obviously will inhibit DNA polymerase, which will inhibit DNA transcription. The most important thing about this side effect wise, you have lactic acidosis, hepatotoxicity. Okay. It can also, you need to monitor creatinine, I think also for tenofovir, but it's more important in adefovir. Okay. Anyways, lamivudine is a cytosine analog, again, will inhibit DNA polymerase. Okay. It's well tolerated. Adefovir, the main side effect is nephrotoxicity. So, in a patient who's taking hepatitis B, one of these drugs, develop flu-like symptoms. What drug are they taking? Interferon, good. If a patient who's taking anti-hepatitis B drugs develop increased creatinine, increased blood urea nitrogen, kidney failure, what were they taking? Adefovir, good. Lastly, is if they were taking it, developed lactic acidosis or hepatotoxicity, what did they have? Or what were they taking? Tenofovir, good. Most likely what you'll be asked is side effects, I think. Okay, I honestly don't remember what we were asked last year about these drugs. But anyways, now we go to this patient over here. What do they have? Good, hepatitis C. You have this, which is the lymphoid aggregation or the aggregates. And then these droplets, the white droplets, is the steatosis. Okay, hepatitis C. Now, hepatitis C drugs are worse than hepatitis B, in my opinion. But anyways, hepatitis C in itself has two types of proteins. Structural proteins, which gives it its structure, and non-structural protein, which is for enzymes mainly, okay? For structural proteins, you have two important structural proteins, E1 and E2, envelope proteins, okay? For non-structural proteins, the one that I want you guys to remember, and as NS5B, which encodes for the RNA-dependent RNA polymerase, there's also NS5A. Then you have NS4A, NS4B, which is for the protease, okay? Why is this important? Is for the drugs used against them. Now, an important thing about hepatitis C is that can we give vaccine for hepatitis C? Is there a vaccine? No. Why is that? Is because hepatitis C is always mutating. Which two regions of this gene is always replicating? If you guys can tell me that. Firstly, one from the structure, one from the non-structure. E2, good, and one from here. NS5A and NS5B, the polymerase, okay? These are always replicating. Another thing, I don't think it was mentioned to you guys, but this is the actual primary reason why we don't have vaccine. It's always mutating. There's a enzyme called an exonuclease, which basically proofreads the strand before it goes to protein synthesis and RNA transcription and so on. This enzyme is called a 3' to 5' exonuclease, okay? Hepatitis C lacks this. So it can't proofread any mutations that's present in the strand. So that's why it's always mutating, okay? This is external, however, it is an important concept for you guys to know, okay? Which makes it make sense. Why do we not have a vaccine for this? It's because of this, okay? In terms of drugs used, you target these proteins, okay? Primarily the non-structural proteins. So you have NS5A inhibitors, which its ending starts with A, okay? Asvir. So you have many of these. Just remember the ending, not gonna lie, it's very hard to remember the drug names. Then you have the NS5B, which starts with B, the ending of it, sulfosbuvir, okay? So buvir. Then you have NS3A4A, which is the protease inhibitors. So Previr, P for protease, Previr, okay? Then you have alternate, which is ribavirin, okay? Anyways, just know the mechanism. NS5A, A, Asvir, okay? NS5B, B, Buvir, okay? NS3A or 4A, protease, okay, protease, P, Previr, okay? Just easier ways to remember these drugs because honestly, it's very difficult, okay? Just know the mechanism of these. For the side effect, it's usually the same: headache, diarrhea, fatigue, okay? The only one is ribavirin, which inhibits synthesis of guanine nucleotides, inhibits IMP dehydrogenase, which is in the DNA synthesis pathway. But anyways, that's ribavirin. The important toxicity and side effect is hemolytic anemia and severe teratogenicity. Okay, that's it for hepatitis C drugs, and that's it for pharma mainly, except one more class of medications. Okay. With this, we're done with hepatitis, viral hepatitis. Any questions for viral hepatitis? Okay. What does this patient have? Very big liver. If you do ultrasound, it's hyperechoic compared to the surrounding structures. Go a bit broader than that. Fatty liver, good. Okay, this is a fatty liver. Fatty liver has two entities. What is it called? Like the pathology itself is steatosis. So steatosis, there's two broad causes of steatosis. Number one is alcoholic steatosis or alcoholic steatohepatitis, alcoholic liver disease, which causes fatty liver. The other one is non-alcoholic steatohepatitis, which is due to metabolic disease, okay? Obesity, diabetes. It's basically due to insulin sensitivity, okay? So this patient has fatty liver. The more important entity from the two, either non-alcoholic or alcoholic, that you guys need to know in detail is alcoholic. You need to know it in detail, which we'll get to. Now here, this is the alcohol pathway. So alcohol gets converted to acetaldehyde through the enzyme alcohol dehydrogenase, okay? Now, the alcohol dehydrogenase has three important implications that causes liver damage in steatohepatitis. Firstly, from the three ways it can cause it, which way causes fatty liver, which is very important, is this. NAD plus is a cofactor, exactly. NAD plus is a cofactor for alcohol dehydrogenase. It gets used up and it gains the hydrogen to form NADH. An elevated NADH to NAD plus ratio causes fatty deposition in the liver, okay? This is what causes the steatosis in alcoholic liver disease, okay? Please remember that fact. The increased NADH to NAD plus ratio causes the fat deposition. Then the alcohol dehydrogenase can cause formation of reactive oxygen species, free radicals, okay, which will break down DNA, proteins, cell membranes, mitochondria, causes cell damage. The last way it can cause cell damage is through acetaldehyde. It produces something called acetaldehyde adducts. What this does is it attracts immune cells. The immune cells will cause inflammation, okay? Immune-mediated damage. Tamam, these are the three ways it can cause steatohepatitis. Which of the three causes steatosis, fatty deposition, NADH? Please remember that. NADH. So what does this patient has? You can see. Good. Alcoholic hepatitis, okay, or alcoholic liver disease. Good. Usually in a patient with chronic alcoholism. Now, there is a sign that you might see associated with alcoholic liver disease, which is this one. What is this? Mallory bodies. Good. Mallory hyaline bodies. Good. Which is this? Yeah. This is an important image to remember. Okay. Mallory hyaline bodies is associated with alcoholic liver disease, not entirely, like it can be seen elsewhere. However, alcoholic liver disease is most associated with this finding. Okay. Now, in another patient who has hepatitis, has cirrhosis, okay, has diabetes, and has brown skin, what do they have? You do staining. Good. Excellent. Hemochromatosis. Good. Hemochromatosis causes the elevation of iron. Okay? It's basically iron overload. Tamam. You do this staining, which is Prussian blue staining, and basically the blue bits or pieces or dots is iron. Okay? Now, hemochromatosis characteristically will have a triad. This triad is cirrhosis or liver disease with brown skin. And this is very important to remember. Brown skin. And lastly is the diabetes. Okay, this triad is key and important to remember for your exam. I'll give it to you as these three findings. Okay. Now, hemochromatosis has two different etiologies. There's primary and secondary hemochromatosis. Secondary hemochromatosis in a patient that requires or that takes frequent blood transfusions because of the high amount of iron in the transfusion can cause hemochromatosis. Primary hemochromatosis is associated with a gene defect. What gene is affected? Okay. What is it encoding for? C287. Okay. HFG gene. Good. What chromosome is it on? 6. Good. HFE gene, chromosome 6. Why is this gene important? It regulates hepcidin function. What does hepcidin do? Hepcidin will increase intestinal absorption. Sorry, it will decrease intestinal absorption. Sorry. Decreases intestinal absorption and decreases decreases intestinal absorption. In patients with HFE gene mutations, this function is gone. So they'll have increased intestinal absorption. So the amount of iron that they have is overloaded. Another thing is that the amount of iron that's being released from cells is diminished as well, which is a function of hepcidin. Okay, it basically does not allow. It allows for iron to get released from the cells. In this case, it won't. Okay, so this is hemochromatosis. How do you treat hemochromatosis? What do you do for the patient? Phlebotomy, which is basically blood transfusion. You can give chelation therapy as well, okay? But usually it's phlebotomies, recurrent blood donations, okay? You tell them, go donate blood, okay? How about this patient? Key image, this one, immediate, okay? Wilson's disease, good. Guys, once you see an eye in the exam, put Wilson's, okay? It's the only thing that has an eye, okay? Put Wilson's. Yeah. Wilson's is a defect in uh, copper transport, okay? Copper will get transported into the bile. In this case, it will be defected, so it won't go into the bile, because that's the primary way that copper is secreted. So it accumulates in the liver, okay? That is Wilson's disease. What gene is mutated in Wilson's? ATP7A, good. Yeah. Do you guys remember? Fun fact, not related to your exam, but there's another one that causes ATP7B gene mutation. Not in GI. If you remember from mold, you won't be tested on this. This is just external information. Anyways, ignore that. If you guys remember Menkes disease, that's ATP7B. Excellent, good. Okay, you guys know. Oh, still. Okay, good. What do you see in Wilson's disease? This finding. What is this finding? Around the eye. Kaiser-Fleischer rings. Good. Other than findings that you might see in Wilson's is neuropsychiatric degeneration. Okay. Now, in terms of the histopathology, what is this? You might see giant cells in this. Giant cells, يعني granuloma, okay? And then you have a degree of steatosis, okay, which is a fat deposition. Granuloma plus steatosis, okay? This is reticulin staining towards a copper, and you can see it's built up. Okay, that's it. Okay, Wilson's disease. Now, all of these patients, all of these diseases that we talked about can lead to this. Okay, obviously hepatitis B, more importantly C, okay, more commonly C, hemochromatosis, Wilson's, alcoholic steatohepatitis, non-alcoholic steatohepatitis can lead to this disease. What does this patient have? Just look at the liver. Cirrhosis, good. Cirrhosis, chronic liver disease, characterize this image as a shrunken liver with nodularity. Okay, cirrhosis. Good. How about this patient? What do they have? Well, okay. Cirrhosis, good. I can see that. Good. Anyways, so what did they have in the cirrhosis pathologic is fibrous bands and regenerative nodules, okay? Which is the fibrous band is portal to portal or portal to central, okay? Bands, and then regenerative nodules in the middle. Again, what type of cell is mediating the fibrosis? Stellate cells, or another name for it. Ito cells, good. Now here in this image, we use reticulin stain to see the type of collagen. What types of collagen will be present in cirrhosis? 1 and 3. What was the normal type? The normal type, type 4. Good. Now for cirrhosis and liver disease in general, here is where we basically talk a lot rather than I'll ask you guys questions as we go. But anyways, for cirrhosis, obviously, as we said, it's chronic liver disease characterized by fibrosis. You have the fibrotic bands and the regenerative nodules. And this is a sign of chronic and severe liver disease. This is a risk factor and a very important risk factor for hepatocellular carcinoma. Now, etiologies, we covered all of this. One etiology that we did not cover is autoimmune hepatitis. Autoimmune hepatitis is seen in females, causes hepatocellular damage, and it's associated, if you guys know, with what type of antibody? You guys tell me what antibody is associated with autoimmune hepatitis. The most important is anti-smooth muscle antibody. ANA could be positive, but it's not specific. Okay, IgG as well. The most important is anti-smooth muscle antibody. Anti-mitochondrial is in primary biliary cirrhosis. Okay, we'll get to that later. Tamam. Now, with cirrhosis, if you see a gross image, there's a lot of nodularity, it's shrunken, and so on. You have many, many things happening in cirrhosis. All of them are important to know. Let's go through them one by one. Jaundice. Jaundice is because of what elevation? Elevation of what? What causes jaundice? Bilirubin. Okay, and it's unconjugated in this case. Spider angiomas are caused by elevation of what? We mentioned this before. Estrogen, good. Polymerythema, same thing. Purpura, same thing. Petechiae are due to what? Platelets, good. Low platelets. Okay, petechiae, low platelets. Okay. Why do they have low platelets? Two mechanisms. Sequestration, because of portal hypertension. Number two is low thrombopoietin. Okay. Then with patients with cirrhosis, they will have portal hypertension, which leads to many things. Okay. So with portal hypertension, if a patient has cirrhosis, has portal hypertension, they will have portal systemic shunts. Okay, where basically the portal circulation and systemic circulation will meet. Tamam? Now, you guys tell me, I'll give you symptoms and you tell me what manifestation of portal hypertension they have. The most important is this one. Okay? Known patient with cirrhosis, alcoholic, let's just say, presents to you with painless hematemesis. Varices, good. Tamam. This is esophageal varices. You have another one, which is gastric varices, which causes a characteristic watermelon stomach. Not too important to know, but anyways, you have varices. Okay, good. This is varices. How about same patient, you look at their abdomen, you do physical examination, and you see distended abdominal veins. Distended abdominal veins. Caput medusa, good. And you guys mentioned, if you have distension going from the left upper quadrant all the way to the right lower quadrant, this is splenomegaly because of splenic sequestration. Good. Lastly, as they tell you that they've had painless GI bleed coming from the rectum. What manifestation of portal hypertension? Hemorrhoids, good. Again, same thing. You might have the portal systemic shunts in the anal canal, which leads to hemorrhoids. Okay, good. Now let's talk about treatment with each of these important, what's it called? Important manifestations of cirrhosis and portal hypertension. Firstly, for portal hypertension, what drug do you give for portal hypertension? Beta blocker, good. Which beta blocker? Most important one to know. Non-selective, which is usually propranolol. Okay, good. Now, esophageal varices, the management is firstly you acutely manage it with hemodynamic stability. You stabilize a patient, try to control the bleed. Now, patients with acute esophageal varices, you can give a certain drug. What is that drug that you can give them? Somatostatin octreotide. Good. Okay, good. How about prophylactic drug? What drug can you give prophylactically for esophageal varices? Beta blocker. Good. Tamam. Now here we already mentioned vascular, you have caput medusa, which is the distended veins over here. Anorectal varices, again, because of the portosystemic shunts. Ascites. Now, ascites, as we mentioned before, is because you have accumulation of fluid that overwhelmed the space of this, we talked about before. It goes and dissipates into the abdominal cavity. Another important thing is you have in both portal hypertension and in ascites, is you have vasodilation everywhere, okay, because of nitric oxide. Now, for ascites specifically, the first thing you need to do is what for patients with ascites? What do you need to do first thing with a patient with ascites? What intervention do you want to do? Drain it, okay? Which is both therapeutic and diagnostic. Why is that so? Is because you want to do the serum albumin to the albumin ascitic gradient, okay? Anyways, this one will just tell you the difference. Do they have ascites due to portal hypertension or other causes? If it's above 1.1, it's due to portal hypertension. Other causes, if it's below 1.1, it's other causes, usually cancer, okay? Anyways, Now, what drug can you give to control ascites? How do you want to manage ascites? After you drain it, you want to control it with good diuretics. Okay. The most important one is spironolactone. Okay. Spironolactone is the most important. What's another diuretic that you can give? Furosemide. Good. Now, with patients with ascites, if they suddenly had fever, pain in the abdomen, they have something called spontaneous bacterial peritonitis. You do drainage, there's a cutoff number of the amount of neutrophils. What is that number? 250, excellent. If it's above 250 neutrophils, this is diagnostic of spontaneous bacterial peritonitis. It's usually by gram-negative, such as E. coli. So what drug do you give? Third generation cephalosporin, which is, give me an example. Ceftriaxone, good. Timma, good job. Then you have reproductive, which is testicular atrophy, gynecomastia, amenorrhea due to elevated estrogen. Okay, we covered this before. Now, neurologic is hepatic encephalopathy and flapping tremor that we talked about, which is astrexis. Due to what in liver disease? Ammonia. How do you want to manage this patient with hyperammonemia? What drug do you give? Lactulose or rifaximin. Perfect. Lactulose is a more important drug to remember. It has three mechanisms to reduce ammonia. Firstly, in the GI, it converts ammonia to the ammonium, which gets excreted. That's number one. Number two is it inhibits the bacteria, okay, in the GI, which will decrease the amount of fermentation metabolism, which decreases the amount of ammonia formed. That's number two. Number three is it increases GI motility, okay? So it washes out the ammonia, okay? These are the three mechanisms. Or you can give an antibiotic, as one of your colleagues mentioned, rifaximin. Good. Now, these are general signs. You have anorexia, GI signs, nausea, vomiting, abdominal pain, and something called fetor hepaticus, which is basically a smell, a breath. It's a fishy smell, okay? Anyways, hematologic, you have thrombocytopenia, anemia, coagulation disorders, splenomegaly, we've discussed this. Renal, they have something called hepatorenal syndrome. Metabolic, we've discussed hyperbilirubinemia, hyponatremia, and then cardiovascular, cardiomyopathy, and so on. And peripheral edema, okay? We've discussed the pharmacology, we've discussed the cirrhosis and portal hypertension, okay? We've discussed everything so far. Is there anything you want me to repeat for this? This is probably one of the most important diseases in GI that you'll be examined on. So now we'll go through the tumors. This patient, what tumor did they have? Do they have? HCC. Why? Give me two reasons. Good, takes up, and washout ended. Excellent. So arterial phase enhancement, which is full enhancement. And then in the delayed phase, or another name is equilibrium, another name is venous phase, it washes out. Excellent. Okay. Hepatocellular carcinoma. Now, hepatocellular carcinoma happens due to, most important is cirrhosis and its causes. Okay. Whatever causes cirrhosis can cause hepatocellular carcinoma. Other than that, you have aflatoxins, which is from Aspergillus. You have hemochromatosis, Wilson's, and then you have something called alpha-1 antitrypsin. What organ did we talk about alpha-1 antitrypsin in before in other lungs? Which causes what disease, what pathology? Emphysema. Okay, emphysema. Good. Remember emphysema, there's two types, centrilobular and panacinar. Panacinal emphysema is caused by alpha-1 antitrypsin deficiency. Centrilobular is by smoking, okay? Just says that. For alpha-1 antitrypsin deficiency, it's usually synthesized and released by the liver. So in the liver, it will accumulate, okay? And you can see it as past positive nodules. Not important to identify, but it was in one of your clinical lectures, okay? Anyways, what tumor marker is elevated hepatocellular carcinoma? Good. Alpha-fetoprotein. This is very important. Alpha-fetoprotein. Usually on imaging, you'll see this sign, and we already discussed it a lot, with cirrhosis. This patient does not have cirrhosis in this case. However, usually patient will come with cirrhosis with this mass. Okay. What does this patient have? HCC. Good. What is this yellow thing in HCC? Yellow is fat is white. This is bile. Okay. So you'll see bile presence in HCC. Do you see mucin in HCC? No, good. Mucin is seen in cholangiocarcinoma. Good. Okay. Anyways, that's the only thing about the pathology that you need to know. The way the HCC presents is usually they have pain, right upper quadrant pain, maybe because of stretching of the liver. They might have acute liver decompensation. They already had cirrhosis, they already controlled, and then acutely they have acute liver failure, basically, because of HCC. Okay. Not too important to remember the clinical manifestation. Usually they'll give it to you as a patient with long-standing cirrhosis comes to you with elevated alpha-fetoprotein. Okay. Then you go from there. How about this patient? What do they have? Good. This is hemangioma. Okay. Hemangioma. Why do you think this is hemangioma? One sign. Peripheral filling. Good. So this is the arterial phase. Early arterial phase, late arterial phase, and this is the venous phase or the delayed phase. So in the arterial phase, in the early phase, it is peripheral. Okay. The contrast is peripherally located. Okay. And slowly it will go into the center. This is diagnostic of hemangioma. Okay. Early, late. تمام. This is it, basically, for hemangioma. It's the most common benign liver tumor. It's a blood vessel tumor. So what you expect to see on histology is this. Okay, so what is this pathology? Hemangioma. So you see endothelial cells with a lot of spaces, which is going to be filled with blood. Okay, so it's that. Now, important concept for patients with hemangioma is, do you want to take biopsy? Why? Why no? Bleeding, high risk of bleeding. Good. How about this patient? Good. Focal nodular hyperplasia. What is this? Stellate scar. Good. Central stellate scar. Guys, this is the only thing you need to remember about this. Not gonna lie, it's always in board exam, in your exam, and everything. Once you see central stellate scar in a patient with a tumor mass and a liver mass, it's FNH. Okay. This is fibrosis that's located in the center. Okay, anyways. Central stellate scar. Remember this finding. Okay. This patient, big subcapsular mass. Good. What subset of patients have this adenoma? Women, more specifically. What age? Reproductive age, around 30s. What about reproductive ages? What's it related to? Estrogen, okay? Estrogen. Either through oral contraceptives or pregnant, okay? Estrogen. It increases the size of this adenoma. In a case, it will primarily give it to you, from what I remember and what I've seen, is a female patient who is pregnant, had right upper quadrant pain, and suddenly a hemorrhage, a ruptured adenoma. Okay. Now, there are three subtypes of adenoma. I just want you to remember one of them, very detailed, is which subtype, gene-wise, is associated with high risk of malignancy. Beta-catenin. What's the first type? Woman, both of them are, but I think, but it's a HNF1 alpha one. And then type 3 is associated with elevated CRP, C-reactive protein, okay? If I remember. Let's see, yeah. First type is HNF1 alpha. Type 2 is beta-catenin. Beta-catenin is associated with high risk of malignancy. That's important to remember. And type 3 is associated with elevated CRP. Okay. This patient who has fever, right upper quadrant pain, you do imaging and you see fluid with air, abscess. Good. Good. Okay, this is liver abscess. Usually from gram-negative bacteria, so Klebsiella, E. coli, and Enterococci, which is gram-positive, Enterococci fecalis, and so on. How about if a patient had bloody diarrhea, then had liver abscess? What organism? Organism. Amoebiasis. What? What's the organism? Entamoeba histolytica. Okay. Bloody diarrhea with amoebiasis, amoebic liver abscess, Entamoeba histolytica. Okay. How about this patient? I'll give you a hint. This patient is a farmer who deals with a lot of sheep and has a dog. Hydatid cyst. Good. What's the organism? Echinococcus granulosus. It's basically one large cyst with many many daughter cysts. Okay. And you might see these septations. Tamam. How do you manage it? No, the septations. Septum. Good. You can give drug, which is metronidazole. However, usually you remove it. Now, what if while you're removing it, or suddenly it ruptured? What will the patient have if it ruptured? Sepsis. Okay. More detailed. This is filled with eosinophils. So anaphylactic shock. Okay. Anyways, how about this patient? Hepatic cysts. Why hemangioma? Hemangioma, you'll see the three phases, and arterial goes from peripheral to central. Remember that for hemangioma. For hepatic cysts, good. These are multiple hepatic cysts, which is associated with what exactly? Polycystic kidney disease. Okay, you might see hepatic cysts in either autosomal dominant or autosomal recessive PKD. Good. Either multiple. To know that these are cysts is look at the density. It's very, very, very low density. So this is cyst, okay? Contrast to this patient who has multiple hyperdense or relatively hyperdense lesions or isodense. Metastatic, good. What's the most common location for metastasis? No, like, where is it from? Of course, it's a liver. More important, more important. Colorectal cancer. Colorectal cancer, go to the liver most like that's the most common reason for liver metastasis. For primary liver disease or primary liver cancer, which is hepatocellular carcinoma, it's most likely going to metastasize to the lung, as one of your colleagues mentioned. Okay. Breast can go to the liver, yes. And pancreatic and GI, gastric cancer can go to the liver. Okay. Most common is colorectal. Now, we're almost done with the liver. To end it off, basically, we have some slides on biochemistry that we need to go over. First of all is a hereditary hyperbilirubinemia. Two of them will cause an elevated unconjugated, two of them will elevate conjugated the bilirubin. So we already mentioned this, but mild decrease of UDP glucuronidase transferase is going to lead to Gilbert syndrome. Gilbert syndrome is usually a patient who is asymptomatic. Later, when they go into puberty, if any stress, like they're fasting or they got an infection, they will have jaundice. Okay? But these patients are okay. It's a benign condition. They don't really need treatment. Okay? Now, similarly, or more dangerous, is Kringler-Najjar syndrome. This is where you have absent UDP glucuronidase transferase, and it's usually diagnosed early on in life. Okay? So, with these patients, they have jaundice, kernicterus, which is basically the unconjugated bilirubin deposits in the brain. This is in children, and very, very young children, infants. Okay, and it obviously will lead to elevated unconjugated bilirubin. Treatment-wise, you need to do two things, plasmapheresis and phototherapy. However, eventually, these patients with Kringler-Najjar, specifically type 1, will lead to liver transplantation. This is the curative treatment for Kringler-Najjar syndrome. However, it is fatal and severe. There is type 2, which can be treated pharmacologically with phenobarbital, okay, which is an anti-epileptic medication. So that's basically Kringler-Najjar. Both of these, Gilbert Kringler-Najjar leads to unconjugated hyperbilirubinemia. Gilbert is very, very benign, not severe at all. Patient who's in puberty goes through acute stressor, leads to jaundice due to mildly decreased levels of UDP glucuronidase transferase. Kringler-Najjar is a very young child who has jaundice, kernicterus, mental retardation, low mental status. They have absent UDP glucuronidase transferase, Kringler-Najjar. Type 1, you treat it with phototherapy and plasmapheresis to try to increase basically the solubility of the bilirubin. Usually, it will lead to liver transplantation. Type 2, you can treat it with phenobarbital. Then these two diseases lead to increase in conjugated bilirubin. The most important thing about these two is it's very, very benign and doesn't really do much. Which of these two, Dubin-Johnson-Roeder, presents with a black liver? Dubin-Johnson. That's it. You need to remember this. Dubin-Johnson, black liver, conjugated hyperbilirubinemia. Roeder syndrome, conjugated hyperbilirubinemia, nothing else. Yeah. It's basically due to defective liver excretion for both of them. Okay. Or impaired hepatic storage. That's it. Okay. Not to like you most likely will see these three. Okay. Or any of these four, honestly. But if you see, for example, black liver, put Dubin-Johnson immediately due to conjugated hyperbilirubinemia due to defective excretion of conjugated bilirubin. Or you'll see Kringler-Najjar, which is the most important, which is dealing with this enzyme. Okay. Now, Biochemistry, you have glycogen storage diseases and you have lipid storage diseases or lysosomal storage diseases. Okay. Glycogen storage diseases, there's many. I want you to master this one, and this one. Okay. These are the more commonly asked ones. Okay. Type 1 glycogen storage disease is von Gerke. It's due to a defect in an enzyme called glucose 6-phosphatase. Glucose 6-phosphatase is related to the pyruvate pathway. Okay. Now, with this enzyme defect, pyruvate will accumulate. Okay. This pyruvate can be converted to lactic acid. That's number one. So lactic acid, other than pyruvate also, it's obviously in the glycogen. It's the first step in glycogen breakdown. Anyways, so you won't have glycogen breakdown, so you'll have severe hypoglycemia. That's number one. Number two, pyruvate will accumulate, gets converted to lactic acid. So you have lactic acidosis. These two signs are important. Severe hypoglycemia and lactic acidosis. You also have hyperalinemia, which is high alanine, okay, in the blood. Severe hepatomegaly, ketosis, because it'll be converted and shunted to ketones because you're not producing glucose, okay? And hyperuricemia as well. This one is very high yield to remember. The case will be a patient with severe hepatomegaly, severe hypoglycemia with lactic acidosis, hyperalinemia, lactic acidosis. You put von Gerke. If they ask about the enzyme, it's glucose 6-phosphatase. Okay. The other one is in Pompe's disease. Pompe's disease is a defect in alpha-1 to 4 glucosidase or acid maltase. These patients, the most important thing to remember about them is cardiac. Okay, they will die due to cardiac failure. So in the question, if you see a patient with cardiac disease, cardiac failure, put Pompe. Which enzyme? Alpha-1 to 4 glucosidase. Okay. Corey and Anderson. Corey is due to CD and then AB. Okay. Anderson B and then CD. Okay. Anderson branching enzyme, cirrhosis. Corey D branching enzyme, like von Gerke, but mild. Okay. Again, these aren't too important. However, you might get Anderson, what's enzyme, AB branching. Corey, which enzyme, CD, D branching, okay? McArdle is in muscle phosphorylase. So these patients will typically present, okay, I just went on a run and I have severe pain in my muscles, cramps and pain in my muscles. This is a patient with McArdle, okay, or easy fatigability or something. Do they have liver manifestations? No. So this is McArdle's disease. Hers is just in the liver. There's no muscle manifestations. So remember, please, these three, because these are the unique ones. Von Gerke, Pompe, McArdle. Von Gerke, severe hepatomegaly, hypoglycemia, lactic acidosis, hyperalinemia, ketosis, hyperuricemia, and so on. Pompe, cardiac. McArdle, muscle. Okay? Is this clear? This is the most important slide in this lecture. There's more details, however, this is what they might ask you. Okay? Tamam. Now, lipid or lysosomal storage diseases, you have a few, okay? I'll give you the key terms for each one because it's a lot to remember, okay? All of them are autosomal recessive diseases except Fabry, which is X-linked recessive, okay? That's key term number one. All are autosomal recessive except Fabry. Now, Tay-Sachs, cherry red macula with no hepatomegaly. That's number one, okay? That's Tay-Sachs. Cherry red macula, no hepatomegaly. Okay, or splenomegaly. Yeah, that's number one. Histologically, what will you find in Tay-Sachs? What finding will you see in Tay-Sachs? Onion skin, okay? You'll see onion skin, which I'll show you in the next slide. Tamam. Which enzyme is defected? GM2 ganglioside, which is this first step, okay? converts GM2 to GM3. This is GM2 ganglioside. Okay. Presents with new degeneration, hyperreflexia, hyperacusis, developmental delay, so on and so forth. Most important thing to remember, cherry red macula with no hepatosplenomegaly. Okay. Fabry disease has a lot of manifestations, but basically has an early and late. Early is peripheral neuropathy, okay, in the legs most likely. Angiokeratomas, which are these red spots in the skin, and hypohidrosis. You have less saliva, I think, that forms. Then you have late, which is progressive renal and cardiovascular disease. Fabry disease, I don't know if it will come because it's less asked, okay? Which enzyme is involved? Alpha-galactosidase, which converts ceramide to glucocerebrosidase, okay? Then metachromatic leukodystrophy, which leads to peripheral demyelination, so you will present with ataxia, dementia as well, okay? Central and peripheral demyelination. The enzyme defected is aryl sulfatase A, which converts sulfatides, aryl sulfatides, okay, to galactocerebroside. Now, these three are important to remember because it has key things to remember about them. This and Tay-Sachs, okay? Krabbe's disease is a defect in galactocerebrosidase, which converts galactocerebroside to ceramide. Okay, the end pathway of all of these steps is ceramide. You need to get to ceramide. So it's cerebrosidase. You'll have neuropathy, degeneration of oligodendrocytes, whatever developmental delay, and importantly that you'll find on histology are globoid cells. And I'll get to a slide next, okay? Goucher disease is the most common out of all of these, and it will present with, again, cherry red macula with hepatosplenomegaly. This is important. On microscope, excellent. Tissue paper, crumbled paper appearance, good. And has another appearance, which is zebra bodies on electron, I think. We'll get to it next. What enzyme is defected? This one, glucocerebroside to ceramide, okay? Number 5. Lastly is name and pick. Goucher does not have the cherry red. It has hepatosplenomegaly. However, it has bone fractures. That's Goucher, okay? Bone fractures. The one that has cherry red macula and hepatosplenomegaly is name and pick, okay? Name and pick, cherry red macula with hepatosplenomegaly. Okay, that's name and pick. Tamam. You will see foam cells. Which enzyme is defected? Number 6, which is sphingomyelin to ceramide. Now, I'll ask you guys questions. Actually, let's go to the next slide and I'll ask you guys questions. Now, in Goucher, as I said, crumbled tissue paper appearance, which you see here. Foam cell, which is a name and pick, it's this big bubbly cell, okay? Globoid cells, as in Krabbe's disease, which are these cells. This is not too important, but you have sulfatides, which you stain them. This is in metachromatic leukodystrophy. On electron microscope, you have zebra bodies. I can't really tell you where they are, not gonna lie, but it's not too important to name and pick. Most important to remember is foam cells, okay? And onion skin is in Tay-Sachs. Now, let's ask question. I'll ask you guys questions from these two broad diseases, okay, which is the glycogen and lipid storage diseases. I have a patient who has cardiotoxicity. What glycogen storage disease do I have? Pompe, good. I have a patient who has hepatosplenomegaly with bone fractures. Goucher. What finding will I see in Goucher? Tissue paper. Crumbled tissue paper appearance. Good. Good. I have a patient who has severe hepatomegaly, severe hypoglycemia, lactic acidosis. What do I have? Von Gerke, good. What enzyme is defected in von Gerke? Good, glucose 6-phosphatase, good. I have a patient who has cherry red macula with no hepatosplenomegaly. Tay-Sachs, good. I have a patient with cherry red macula with hepatosplenomegaly. name and pick. Are these clear to you guys? Good. Any questions from the liver? We're done with the liver. You might get one of them in this slide. Okay, you might get one of these in OSPE, but usually it comes in MCQ. Again, this whole crash course is a full exam review. I mean, it's MCQ, SAQ, OSPE. This isn't the usual OSPE reviews. So that's why it's everything. But in OSPE, you'll most likely get the pathology, pharma, one pharma question I think you'll get. Clinical, and micro and radiology. Okay. I'll tell you guys specifically in clinical, but it's whatever I put in this crash course so far. Okay. So anyways, next thing is gallbladder and biliary tract diseases. Okay. Now, let's go into this. Inshallah, this one is easy with the pancreas. The next section is easy. Okay. In terms of the anatomy of the gallbladder and the biliary tree, first you have the gallbladder over here, which is multiple parts. You have the fundus over here, body. This part, it's called the heart and spout. Another name you can give it is infundibulum. The cystic duct, which has many, many, many ways it can present with. Can have two cystic ducts, a cystic duct that goes to the common hepatic or one that goes to the common bile duct, two cystic ducts, many different ones, not important to you guys to remember. But usually a most common one is it's going to go into the common, it's going to join with the common hepatic duct to form the common bile duct. Now, starting from up here, you'll have right and left hepatic duct joins together to form the common hepatic duct, joins with the cystic duct to form the common bile duct. The common bile duct goes all the way over here, which is the ampulla of Vater, which is basically the joining of the common bile duct with the pancreatic duct. Okay? And it goes into the sphincter of Oddi to the duodenum. In terms of the blood supply, you'll have the hepatic artery, you have the common hepatic artery, then hepatic artery proper coming from the celiac artery, common. So let's just say you have this, which is a celiac artery, common hepatic artery proper, goes all the way up here, then divides into the right hepatic artery, then the left hepatic artery. The right hepatic artery will give off, obviously goes to the liver and will give off one important artery to the gallbladder, which is a cystic artery. Okay, let me draw this better. So anyways, the cystic artery will be somewhere around here. It will come around here. So to identify this surgically, there is a triangle, which is this triangle, which is a Calotes triangle. Okay, anyways, not too important for you guys to know. The lymphatic drainage of the gallbladder and biliary tract from up here is in a node that's present in this triangle as well. It's called the Calotes node. Okay, this is in clinical, purely in clinical. Okay, anyways, why is this important triangle? Is because you want to ligate this artery when you're removing the gallbladder. Okay, this is applied clinical anatomy. Anyways, in this patient or in this diagram, we have this ligament over here, which is basically the hepatoduodenal ligament. What is the hepatoduodenal ligament? It contains three important structures: the common bile duct, the hepatic artery, and the portal vein. If a patient has any liver hemorrhage, you clamp this ligament, and it usually will tell you the source of the bleed. If the bleeding stops, it's one of these arteries or these vessels, either the portal vein or the hepatic artery. If it's not from this is either from the inferior vena cava, which is back here, or the vein that goes into the inferior vena cava, which is the hepatic vein. This is also applied clinical anatomy. Okay. So, as we mentioned, the first line investigation you do for hepatopancreatibiliary system is ultrasound. Very important imaging. Okay. This is the gallbladder. It's anechoic. Okay, you can see the slightly echogenic borders of the gallbladder, but everything is normal in this case. You don't see any sludges, stone, polyps, or tumors in this case. Okay, This is a normal gallbladder. It's distended. Okay. Now, kind of a concept question, but is this patient fasting or not fasting? Or did they just eat? Fasting, good. It's distended because when you eat, what happens is you have cholecystokinin, which contracts the gallbladder, so it won't appear this dilated. Okay, and distended. This is important for one of the pathologies. Now, if you have a patient with suspected gallbladder stone, you did ultrasound, you can't see it. What's the second line investigation that you can do? Actually, let's leave that for later. Let's leave this. When you're trying to evaluate the biliary tree, what investigations can you do? ERCP or MRCP? ERCP is called endoscopic retrograde cholangiopancreatography. Okay, long name. But anyways, it's a cholangiography. Cholangiography is you're trying to see the biliary tree. Okay, two ways to do it: ERCP or magnetic retrograde cholangiopancreatography. Okay, anyways, endoscopic, you go through endoscopy through the esophagus, go all the way to the stomach, to the duodenum, go all the way to the second part of the duodenum. You put this probe into the ampulla of water. Okay, and you inject a dye. The dye will go all the way to the distal point where it can't go anymore. When would this distal point be? If you have a stone, okay, that's obstructing over here, for example, let's just say over here, you have a stone. This whole part won't be visible, okay? So this is it. In this case over here, this patient, can you see a gallbladder? Yeah, I can't either, okay? It might be this small piece of it, but this patient most likely underwent a cholecystectomy, okay? And a patient who has cholecystitis, there will be a filling defect not going to the gallbladder, okay? But I'm pretty sure this is part of it. Okay, anyways. Tema, this is ERCP. Now, ERCP is more invasive because you're going in with an instrument and you're basically going into the duct. So what's one complication that can occur, especially to this area? What's this duct? Pancreatic duct, so pancreatitis. ERCP is one of the causes of pancreatitis, okay? Anyways, can be perforation, bleeding. These are general complications. Anyways, now ERCP, since you're going in with this probe or this piece, it can be used as a diagnostic and therapeutic intervention because this can actually break the stone. Or if there's a stricture, you can remove the stricture. You can alleviate the obstruction. So this is both diagnostic, you can see the defects, and therapeutic. You can remove it directly with this piece over here, this thing. This is diagnostic and therapeutic. In any patient with common bile duct diseases, especially cholecystolithiasis, which is common bile duct stone, ERCP is the first line because, not the first, gold standard because it's both gonna diagnose it for you and you can manage it there. Okay. Anyways, no, you can't. You can't go all the way. Okay. Usually for gallbladder, it's you can use this one, but not ERCP. Okay. Why can you use this one? This one is magnetic resonant cholangiopancreatography. This one uses the bile itself as the dye. Okay, uses the bile. So you mostly see it from proximal up here to distal, okay, or superior to inferior. So the filling defect that you might see is distal to this. It's below this, inferior to this obstruction. In ERCP, it's the opposite. If it's over here, you won't see anything going up here because you're injecting the dye from here. Okay, this is the differences between ERCP and MRCP. Can you use this for therapeutic interventions? No. There's no therapeutic interventions with MRCP. Okay. For gallbladder diseases, what is the first line investigation? Gallbladder ultrasound. Good. Okay. For gallbladder stone, you have a second line, which we'll get to later, but it's not any of these. What do you mean? Yeah, exactly. What do you mean by filling? Yeah, okay. So this is ERCP, MRCP. Anyways, now we go into the pathologies, which is mostly all going to cause obstructive jaundice, except gallbladder diseases in general. There's one set of gallbladder diseases that might cause it. So, uh, so obstructive jaundice will cause what type of hyperbilirubinemia? Conjugated or unconjugated? Post-hepatic. Conjugated or deconjugated or unconjugated? Conjugated, good. So it causes conjugated hyperbilirubinemia, which causes jaundice. So you have mural or intrinsic. The way this is divided, I don't really like. But anyways, you have, okay, if it affects in the wall itself or inside the lumen or inside outside. That's the way I like to do it. I don't know why this is a bit different. Anyways, so inside the wall itself, in the wall defect is the primary sclerosing cholangitis or sclerosing or primary biliary cirrhosis. Those two causes obstructive jaundice. We'll get to them specifically later. These are two important ones. Inside the lumen, gallstones, which goes to the common bile duct and obstructs there, okay, which is what we call choledocholelithiasis. Choledochal cyst can cause obstructive jaundice, a cyst. Strictures, which is from a previous procedure, for example, okay, and infections, which is from the flukes. So Clonorchis sinensis, for example, and schistosomiasis specifically. I don't think you need to remember this, but Mansonian japonicum, okay? Anyways, so something to remember importantly about a choledochal cyst is it's a risk factor. What's a risk factor for? Cancer. What type of cancer? Cholangiocarcinoma, good. Okay, choledochal cyst, the most important thing to remember is it's a risk factor for, it's a congenital defect, can be presenting early, sometimes undetected, so an adult can present with it. Signs of obstructive jaundice, important thing to remember about this is that it can lead to cholangiocarcinoma, so you have to always remove it. Good. Now, extrinsic is something from outside. Now, this stone can go all the way to the ampulla and obstruct there. Pancreatic head tumor, okay, which is the most common site for pancreatic tumors, can obstruct the ampulla, so you have obstructive jaundice. Good. Important embryological disease that can present with, actually not really, so I won't mention it here. As anyways, ampulla levator tumor, again, same thing, will cause obstruction, duodenal tumor, or as we mentioned before in the previous session, the duodenal diverticulum, if it's intramural, can cause obstructive jaundice, okay? Extrinsic from outside, the important ones I want you to remember is Merizi syndrome. Merizi syndrome is if there's a stone, I'll explain this later in more detail, but there's a stone in the cystic duct or in the infundibular part of the gallbladder, which is somewhere around here, if it obstructs the common hepatic duct, not the common bile duct, the common hepatic duct, which is before it joins with the cystic duct. I'll show you that later. Tamam. That's pretty much, and with stricture as well. It can form from outside and adhesions from outside. If someone had a surgery before, can present with it as well. Okay. And as I said, with patients with obstructive jaundice, the bile is not going into the stools. So what color of stool would they have? Gray or pale stool. Good. What color of urine? Dark. Good. Now, the most important pathology in gallstones, the biliary tree, is going to be stones, okay? So, stones, you have two types of stones. Or, yeah, two general types of stones. The most common is cholesterol stones, okay? So with cholesterol stones, you have high cholesterol, decreased bile salts, for example, that leads to supersaturation and then leads to cholesterol stones. There's more to the pathophysiology. I don't think, for example, there's more to the pathophysiology, but this is a super summarized version of it. More importantly, it will give it to you in a patient with this description. A female in her 40s, has 5 babies. Okay, we got this in our surgery exam, exactly like this. Okay, female, 40 years old, has 5 kids, presents with right upper quadrant pain. What do they have? Gallstone, okay? So the risk factors is the 5 Fs. There's a 6th one as well, but I forgot what it was. So anyways, it's a female, fat, obese because of high cholesterol, fertile, again, high estrogen. There's high estrogen, which will increase the cholesterol, and then progesterone as well, which will decrease the mobility of the gallbladder. Okay, that's just fun fact for you. 40 years old and fair-skinned. Okay, this is cholesterol gallstone, which is the most important one, most common one. You have other, which is pigmented stones, which is either black or brown. Black is associated with hemolysis, hemolytic anemias. Okay, and we discuss how it can cause stones and heme onc. Okay, but basically it's because of high bilirubin. Okay, and we discussed it also here. The other one is brown stones, which is because of infection. Okay, that's that. Now, how do these stones present with? There's many, many manifestations. So, the presence of stones in the gallbladder is something that we call cholelithiasis. It's just gallstones. Okay. These are typically asymptomatic. Okay. Now, I'll ask you guys, I'll tell you a manifestation and you tell me what stone manifestation is this. Okay, I'll give you a case. A patient who just ate and has transient right upper quadrant pain that went away. What do they have? Because of cholecystokinin? Yes, exactly. What is that called? It's in the cystic duct, but then goes back. Biliary colic. Okay, what is a biliary colic? It's transient pain. Okay, typically in the right upper quadrant pain. It's transient. Why? Is when you eat a fatty meal, for example, you have a lot of cholecystokinin. So the gallbladder will contract. It pushes the stone to the cystic duct and it obstructs the gallbladder. Once it relaxes a few hours after a meal, it goes back. The stone gets out of the cystic duct because it relaxes now. So that is what we call a biliary colic. Good. How about this manifestation over here? C. It obstructs the cystic duct. The patient would have right upper quadrant pain, fever, leukocytosis, inflammation. Uh, exactly. Cholecystitis. Good. What physical sign will they have of cholecystitis? To give you a hint on the description, exactly, good. Murphy's sign. Murphy's sign is you ask the patient to inhale. What will inhalation do? The diaphragm will push the gallbladder down, so it's more palpable. And of course, it's painful in cholecystitis, so the patient will arrest inspiration. They'll stop inspiration. That's Murphy's sign. The pain in cholecystitis will radiate to the shoulder, right shoulder or the right scapula regions in the back, okay? Now, you have this patient over here. that has a stone in the common bile duct. What is that called? Cholelithiasis. Lithiasis. I mean stone. Now, with these patients with cholelithiasis, because of the bile accumulation that happens with cholelithiasis, infection can happen and inflammation of the common bile duct is usually ascending. What do we call this? Cholangitis, ascending cholangitis. Good. Now, ascending cholangitis, the patient has right upper quadrant pain, fever, and jaundice. What is this triad called? Charcot's triad. The patient has right upper quadrant pain, jaundice, fever, hypotension, and altered mental status. What is this pentad called? Raynaud's pentad. Good. Okay. Memorize these two for ascending cholangitis. It's usually caused by, first you have a stone or something that's obstructing it, cholelithiasis, stricture, something, okay, that causes the bile stasis. Infection. What organism can cause infection? Both cholecystitis and ascending cholangitis, usually E. coli, Klebsiella, and Lum. Okay, good. How about here? This stone is obstructing the pancreatic duct. What will this patient present with? Pancreatitis, good. If it obstructs here in the ampulla of Vater, both will have ascending cholangitis and pancreatitis, okay? How about down here? It obstructed in the terminal ileum, the stone, because of a fistula. We covered this in the last part of the crash course. Okay, ileus, gallstone, ileus, good. Tamam. No, it's okay. Now, the first line is, as I said, ultrasound, good. What does this patient have? Cholecystitis. Is it calculus or acalculus? Calculus. What is acalculus? What is it caused by? Stasis. Good. Stasis. It's usually with no stones there. Okay. Stasis of bile can form sludge. Good. With stasis of bile, what patients will have it? Patients who are on TPN, total parenteral nutrition, because you're not stimulating the gallbladder, because food will cause cholecystokinin release, which will cause contraction of the gallbladder, and so on and so forth. Patients who are hospitalized, debilitating patients, will get acalculous cholecystitis. Good. What is a sign in imaging and ultrasound? Okay, give me the actual name. Posterior shadow. Good. You gave the radiology crash course, so you should know this. Okay. So, anyways, uh, this patient has thickened gallbladder walls, and pericholecystatic fluid accumulation, pericholecystatic edema around it. Okay. Thickened walls, a distended gallbladder, and so on. These are the findings that you can see in acute cholecystitis, sorry. Again, what do you see on this sign? You have an echogenic stone with posterior acoustic shadow. Okay. Now, if you can't see anything in ultrasound, what's the second line to diagnose cholecystitis? I showed you the slide. HIDA scan, good, which is nuclear medicine scan. Okay, as a scintigraphy, it uses nuclear medicine targeted towards a bile. You don't need to interpret it, okay? But you just need to know. If you can't do ultrasound or it's inconclusive, second line is HIDA. You need to know this, okay? Anyways, it'll show you a filling defect that's not going to the gallbladder, okay? Which is in this case over here. It's both. Yani cholecystitis is due to the stone. However, cholelithiasis will usually be asymptomatic patients. Okay, cholelithiasis will usually be in asymptomatic patients. Exactly. No, in the common bile duct, no. This is not second line for this. Okay. You usually don't do this. This is for the gallbladder. There is the first or there's the first line, which is ultrasound, and there's a gold standard you do for any patient with common bile duct stone, which we'll get to that soon, inshallah. How about this patient? A patient with cholecystitis, however, it's complicated. I mean, emphysematous, good. So this is emphysematous cholecystitis. You can see air in the walls of the gallbladder. Tamam? This is emphysematous cholecystitis. Now, for gallbladder, these two diseases, cholelithiasis and cholecystitis. Cholelithiasis usually it just means the patient has gallstones. Okay, it's asymptomatic usually. Okay, so the patient won't present with anything. It's usually an incidental finding. Management wise, you do nothing for these patients. You do nothing because it's not causing obstruction, not doing anything for these patients. Okay. Cholecystitis, no, you're going to need to do something with this patient. So first line of management, or first thing you do in management is stabilize the patient. You keep the same thing as we discussed in small bowel obstruction, the same thing that we're going to discuss in pancreatitis. It's the same stabilization techniques. You keep the patient NPO, non-peroral, IV fluids, analgesics to relieve the pain, antibiotics as well, antipyretics to decrease the fever, nasogastric tube to decompress the stomach, decrease the amount of food that's there so you don't stimulate the gallbladder. All of these, okay? And then you assess the patient. The gold standard management of cholecystitis is what? What do you need to do for this patient? Remove it, exactly. Remove the gallbladder. Tamam? Cholecystectomy, exactly. So you do a cholecystectomy. Now, when do you do a cholecystectomy is not too important, but basically you can divide it to mild and then moderate and severe, okay? Mild, you give them antibiotics and then you wait a bit, and then you do the cholecystectomy. Moderate and severe, you usually just do the cholecystectomy right away, laparoscopic, which is through probes. Okay, you put two holes and you just do it. It's less invasive, cosmetically better. Then you have open, which is you cut the patient open. This is usually an elderly that you do because it's easier to do. Okay. Do you need to know all of this? I doubt it. Okay. All I want you to know is the first thing you do is stabilize this patient from the way I told you, and then you eventually do a cholecystectomy. The most important thing to remember is how do you diagnose it? What's first line? What's second line? What's the pathophysiology? What's it caused by? And all that stuff. Okay. And we discuss all of that. Now we need to go through all of these so you know the differences between these. What does this image have? What do they have in this image? First one on the stone. Good. How about this patient? Sludge. Good. It's less bright than the stone. How about this patient? Polyp. Good. How can you tell the difference between polyp and stone clinically? What do you ask the patient to do? Gravity. Which you ask them to move. Good. Polyp is fixed. Stone is not fixed. It'll move when the patient moves. How about this patient? There's color on Doppler. Tumor. Good. Cancer. Cancer or tumor. There's color on Doppler. You can see the red and blue, which means that it's most likely tumor. Okay. This patient over here, what do they have? Good. Chronic cholecystitis. Patients who have long-term acute cholecystitis can repeated bouts can later develop chronic cholecystitis. Exactly. What is a sign called? Porcelain gallbladder. Why is this porcelain gallbladder important? What is a risk factor for? Cancer. Good. So this is a risk factor of gallbladder cancer. Okay. Presence of this porcelain gallbladder. You can see fibrosis, it's white. There's many stones over here. So anyways, it's white and so on. Most important thing to remember is the porcelain gallbladder. So what do you need to do for this patient? Remove the gallbladder. You need to remove the gallbladder so the risk of cancer is decreased. Okay. How about this patient over here? This is the common bile duct. This is on MRCP. Again, this is the first part, and then there's inferior filling defect. Good. Cholelithiasis. Excellent. So this is a cholelithiasis. First line you do is ultrasound. What will you see in ultrasound? You might see in the gallbladder itself the presence of stones in the gallbladder. Okay? Because what causes cholelithiasis? Gallstones. Goes from the gallbladder, goes all the way down. Okay? So that's how it's caused. As well as this feature, which is distended bile ducts. Okay? You might see a stone in the bile duct as well, as you can see here. Okay? Anyways, the best imaging modality to visualize it is MRCP. However, what is the gold standard intervention? Gold standard intervention? ERCP. Why ERCP over MRCP? Exactly. It's both therapeutic and diagnostic. You can remove the stone immediately as you do ERCP. Exactly. So that's why it's preferred. First line is ultrasound. So gold standard is ERCP. Okay. You go in, you remove it. Now, if it has infections on, you already mentioned like ascending cholangitis, we mentioned Charcot's triad and Raynaud's pendant. Okay, memorize these features. Okay. How about this patient? What do they have? Ileus, good. Three features. What's this feature? We covered this in the last part of the crash course. This is air in the biliary tract, pneumobilia. Okay, so here's a triad. First one is pneumobilia, characteristic of gallstone ileus. Why? Is because it's a fistula between the gallbladder and the small bowel. Small bowel has air. So air will go to the gallbladder, to the biliary tree, so you'll have air in the biliary tree. Okay. Number two is the presence of stone in the terminal ileum, as you can see here. Number three is evidence of small bowel obstruction, which is, as you can see in this patient, has distended small bowel. Okay, this is a triad. Okay. Now, Merisi syndrome is basically this. You have a stone that's in the cystic duct or the infundibulum, which is over here, this part of the gallbladder, that's causing external obstruction of the common hepatic duct, which will cause both cholecystitis and bile stasis, which can present as ascending cholangitis in this patient. Management, you remove the gallbladder completely. You remove this portion over here because it's inflamed and it's going to recur. And you do something, and you remove the rest of it as well. You do something called a bilo-enteric anastomosis. You connect this portion of the biliary tree that you have left with the bowel. Okay? Do you need to know that? I doubt it. I highly doubt that. Okay? Just know that Merisi syndrome, if you have a patient who has a stone in the cystic duct, but then has ascending cholangitis as well with it, obstructing a common hepatic duct, it's Meniere's syndrome. Okay. Now, these patients who have cholelithiasis, obstructive jaundice, later on presents with this. What do they have? Biliary cirrhosis, primary or secondary? Secondary, good. Primary is a defect in the biliary tract itself. Secondary is due to these defects that I talked about, which is stones, stricture, cysts, Meniere's syndrome, all of these over time will cause secondary, because of these diseases, biliary cirrhosis. It goes back to the liver and will cause damage. Grossly, it will present as this yellow-green liver, which is because of the bile stasis in the liver. And then you'll have this, which is cirrhosis. Okay? You can see the fibrous band and then these regenerative nodules. Okay? This is secondary biliary cirrhosis, the more common type of biliary cirrhosis. Okay? Because of secondary causes. So how do you manage this patient? You treat the secondary causes. Okay? How about this patient? Primary biliary, good. Primary biliary cirrhosis or cholangitis, a new name for it. I don't think you guys, it's important to you guys, but there's a new name for it as well. It's called primary biliary cholangitis instead of cirrhosis, but it's the same thing. Primary cirrhosis or cholangitis. Important thing is, will it present more in females or males? Females, good. What is an important symptom do they that these patients will have? Itching, good. Important, guys, in the case, female patient in their 30s, 40s, pruritus, itching, severe itching, okay? The third high yield factor to know about this is what antibody will be positive? Anti-mitochondrial, excellent. What do you see here? Now, this affects small or large biliary ducts. Small, good. So it affects the small biliary ducts, and you can see granulomas with giant cells, as you can see in this patient over here. Okay, with eventual fibrosis later on, lymphocytic infiltration, that's usually periportal, okay, around the portal. But anyways, just for this one, remember it's granulomatous destruction, so you see a granulome. That's the most important thing to remember about this. Important, female, 30s to 50s, or that age group, associated with pruritus, severe. Antibody is anti-mitochondrial. Good. How about this patient? Good. Primary sclerosing cholangitis. What image modality is this? ERCP or MRCP? This is ERCP. Good. If it's a darker background, it's MRCP. That's how I know the difference. Okay, this is ERCP. Anyways, this is primary sclerosing cholangitis. Okay. Now, primary sclerosing cholangitis is it in males or females more? Now, good. It's in males more. Uh, Now, primary sclerosing cholangitis is associated with what other disease? Ulcerative colitis. Good. The presence of primary sclerosing cholangitis in a patient with ulcerative colitis increases the risk of what? Cancer. Where? Colorectal. Good. Okay, colorectal cancer. Good. Okay, I explained why in the previous part. What do you see here? This is the beading appearance. Stenosis with dilated duct. Okay, good. What antibody is present in primary sclerosing cholangitis? Similar to UC. Pianca, good. Perfect. What do you see here? Good. Onion skin fibrosis and PSC. This is the onion skin fibrosis. This blue staining is the fibrosis that you can see. This image is high yield, this one. Yeah, memorize this image. You will get this in OSFI, most likely. Um, uh, Now, a patient with porcelain gallbladder or chronic cholecystitis developed into this. What do they have? Chronic cholecystitis, gallbladder. Not cholangio. Cholangio is in the bile ducts. This is gallbladder carcinoma. Okay. This is in the gallbladder. Okay. It's gallbladder carcinoma. Okay. Anyways. Okay, so this is just gallbladder carcinoma. It's usually in a patient with chronic cholecystitis. Porcelain gallbladder from it usually will develop into chronic cholecystitis, usually in a very elderly female. Important clinical sign. I will describe it to you and you tell me what sign this is. Okay. Uh, I have this patient who has a palpable, painless right upper quadrant mass. Painless right upper quadrant mass has been losing weight. What is the sign called the right upper quadrant painless mass? Yes, it's something with a C. What is it? Courvoisier sign, something like that. Okay. So now, this patient who had primary sclerosing cholangitis or had fluke infection or had biliary or choledochal cyst, cholangiocarcinoma. Two important finds radiologically that I want you to know. It's firstly, it's a heterogeneous mass. Okay, that's number one. It's a heterogeneous mass, large heterogeneous mass, and distended bile ducts. Okay, these are two important findings that I want you guys to know. Heterogeneous mass and distended bile ducts. You see these? These are very characteristic of cholangiocarcinoma. This patient, same thing, cholangio. This patient, or this histological image, will it have mucin production or no mucin? Mucin, good. The mucin is going to be produced into the lumen, and you can see that these cells have abundancy of mucin in the cells itself, okay? This is mucin. This is to differentiate it from hepatocellular carcinoma, which has bile with no mucin. This might have bile, but most importantly is this has mucin, okay? Tamam. And we are done with the biliary and gallbladder. Do you guys have any questions with that section? Is it all clear? To move to the pancreas and we're going to be done. I think all good. Good. All right. So let's go through this section a bit faster. Very easy, two pathologies to remember, pancreatitis and cancer. That's it. Now, in terms of anatomy and embryology, it's very important to remember is that you have firstly the head. The head, its relationship to the common bile duct and the ampulla of Vater. So you have any head cancer, pancreatic head tumors, this can cause obstructive jaundice, okay? So do you have the head, the neck, the body, the tail? Is the pancreas retroperitoneal? Yes or no? Except tail. Good. Yes, except the tail. Good. All right, perfect. The tail will be in the splenic ligament, okay, which is intraperitoneal. Tamam. Anyways, so you have this part. This part of the head is also called the uncinate process. Not too important to remember, but anyways, you have two ducts of the pancreas. You have this one, which is the main pancreatic duct, and then you have the accessory or the minor or the accessory pancreatic duct. The accessory will drain into the minor papilla, not too important again. Then you have this one, which is the sphincter of Oddi. Embryologically, there's two diseases I want to remember, something called a pancreatic divisum and annular pancreas, okay? Basically, what happens is you have two buds, ventral and dorsal. Ventral will start on the other side of or ventrally, this is the anterior part of the body or the stomach, and this is the posterior, okay, because it rotates this way. It will rotate to the other side around 270 degrees to reach the dorsal pancreatic bud, where it will fuse. Now, the main pancreatic duct will fuse with the accessory pancreatic duct together later on, okay? Failure of fusion of these two ducts will cause what? Pancreatic divisum, which is a risk factor of what disease? Pancreatitis. Good. That's all you need to remember about pancreatic divisum and pancreatitis because of it, okay? The second is this ventral bud. It can fuse and, it can rotate and form a ring around the duodenum. What is this called? Annular pancreas, which can cause what? Obstruction. Good. Okay. Perfect. That's about it for the embryology. Imaging-wise, the first line imaging that you do, ultrasound. Again, same thing, same reasons why. You might see enlarged pancreas on ultrasound. It's an easier method to use. However, gold standard, best imaging is CT scan. Okay, you need to do CT scan in a patient with pancreatitis and chronic pancreatitis. You need to do it, and that's how you identify most of these pathologies. This is the head of the pancreas over here. This is the body. The neck will be somewhere around here, and this is the tail. Okay. Again, it's mostly retroperitoneal, except this, which is the tail, which is going to be connected to or inside the splenic ligament. Okay. Histology, you have two main bodies of cells. Which is the less common, which is the islet of Langerhans, which has the alpha, beta, gamma, delta cells, okay, mainly. Okay. Then you have the acini, which are all of these cells, which is for the exocrine pancreatic function. And then you have these ducts, which drain everything, okay? Why is this important? Is in acute pancreatitis, it will affect the acini. In chronic pancreatitis, it usually will affect this first and lead to damage to this, okay? Which we'll get to it later on. Now let's go through the diseases. What does this patient have? This is in the stomach. Ectopic pancreas, good. Most common location is in the stomach, okay? They might have epigastric pain. You do ultrasound, you see a mass, it might be scary, you do it, you check it, it's ectopic pancreas. You biopsy, you'll see this on biopsy, okay? This patient, what do they have? I'll tell you. They have epigastric pain radiating to the back. Pancreatitis, good. Acute pancreatitis. So, acute pancreatitis, let's talk about the risk factors, pathophysiology, diagnosis, and treatment in this slide, okay? This is, as you said, acute pancreatitis. I don't think I have anything else about it. Okay, so the risk factors or the etiologies is a mnemonic to remember. What is that mnemonic? I get smashed, good. There is a newer one, which is I get PP smashed. I'll get to what the two P's are, but you're not required to know them. We already talked about one of them, so might as well say it. Anyways, let's go through them one by one. I. What is I? Idiopathic. Good. So idiopathic, we don't really know the cause. Good. G. Gallstone. What's the most common cause of pancreatitis? Acute pancreatitis. Gallstones. So G, gallstones is the most common cause. Okay. What's E? What's E? Ethanol, alcohol, which is the second most common cause. Good. What's T? Uh, Trauma, good. Trauma. T is trauma. Okay. What is the most common cause of acute pancreatitis in children? Trauma. Remember that. Okay? Remember this. We got it last year and a lot of people got it wrong. Yeah. Anyways, trauma. Remember that. What's the first S? Or just tell me what the S is. You guys need to memorize all of these causes. That's why you need to go through them. So the first S is steroids. This, what's the M? It's infection. Mumps. Good. Okay, mumps. What's the A? Autoimmune. Okay. What's the second S? Scorpion sting. Good. Good. What's the H? There's two in H. Hypercalcemia, good, which activates the enzymes. What's the other one? Hypertriglyceridemia, which is usually above 1,000. It's very, very, very high triglycerides. What's the E? ERCP, as we mentioned before. And then lastly is D, well, drugs, good. Again, most common cause of acute pancreatitis everywhere, it's gallstones. Second most common, alcohol. These two are the most common causes. In children, trauma. Need to remember this, okay? Now, you have two entities of hereditary and autoimmune pancreatitis. So about hereditary pancreatitis, there's two important types of it. There's the autosomal dominant, autosomal recessive. Autosomal dominant hereditary pancreatitis is related to what gene? PRSS1. Good. Autosomal recessive, SPINK1. Good. The autosomal dominant variant, which is PRSS1, it encodes for trypsinogen, which activates into trypsin, which activates every other enzyme, which leads to the destruction, okay? Autodigestion. SPINK1, it encodes for trypsin inhibitor, which inhibits trypsin. If you have defect in this, it won't inhibit trypsin, so it causes the pancreatitis. Then you have autoimmune pancreatitis, which has two entities. What's number one? Just give me what's elevated in it. Main antibody. There's two. Okay, so there's lymphoproliferative, which is IgG4. And then there's the second one, which is the idiopathic duct something. Okay. Something. Okay. Idiopathic duct centric. Yeah, exactly. So that's the two entities for autoimmune hepatitis, autoimmune pancreatitis. Okay. Now, what do these etiologies cause? So number one is obstruction. If you have gallstones or something, this will cause stasis of the pancreatic secretion in the pancreatic ducts, autoactivates and destroys the pancreas. Okay. The most important enzyme is trypsin. Why trypsin? Trypsin can activate everything else. Okay. Then you have the acinar destruction, which is basically due to alcohol, toxins, and so on, drugs and all that, which destroys the acini. You have dumping of all the secretions, and obviously the pancreatic secretion, the enzymes will auto activate and also digest the pancreas. Okay, these are the main reasons, and it causes autodigestion. Clinically, it will present as epigastric pain radiating to the back with one of these risk factors that the patient has. So either they had gallstones, they had cholelithiasis, or they are alcoholic and drink alcohol. They have mumps, so they have parotitis or something, or something with the testes, okay, or orchitis. Okay, so one of these risk factors, okay. How do you diagnose it? There's a criteria. You need 2 out of 3 of this. Firstly, is the clinical signs that the patient has.
Epigastric pain radiating to the back, nausea, vomiting, fever, and so on. Okay? Most important is epigastric pain radiating to the back. The second thing is, what lab test do you order? Lipase or amylase? Which one is more specific? Lipase, good. Why? Because amylase can be synthesized, secreted somewhere else, such as the saliva. Okay? Lipase is more specific. Lastly is, what's the third part of the criteria? Do you guys know? You have clinical manifestations, lipase or amylase, or CT imaging. Good. Which is this one? You have an enlarged pancreas with peripancreatic fluid collection, edema. Okay. You might see necrotizing pancreatitis as well, which will have emphysema and air accumulation somewhere around here. We'll get to a picture of this later. And so on. You might have evidence of a stone in this image because of the gallstone that's obstructing the pancreatic duct and so on. So you need 2 out of 3 of these to diagnose a patient with acute pancreatitis. How do you manage a patient with acute pancreatitis? Supportive, good. We mentioned it already. You keep them NPO, give IV fluids, analgesics, antipyretics if they have fever, and NG tube decompression. Okay, remove everything just so there's no food to simulate the pancreas, and make sure you don't give them anything orally, okay, to simulate the pancreatic, and you let the patient rest. Okay. Is there surgery involved? Sometimes with surgical debridement. Why? Because you might have cytokine release that leads to destruction of the cytokine and the enzyme release itself around the entire peritoneum. So you might have to do surgical debridement. Okay, remove the necrotic parts of the abdomen. Okay. Manifestations, other ones that are more rare that you can see, just so I make sure I complete everything, is abdominal distension and abs or diminished bowel sounds. Patients with acute pancreatitis might have paralytic ileus. Why is that? I don't know. Okay, but it's something just to note. Now, complications. What is the most common complication of acute pancreatitis? This is very important. Pseudocyst. Most common complication is pseudocyst. All the other complications you might mention, which is chronic pancreatitis, shock, and so on, is true. They are complications. The most common one, it was written in one of your slides, pseudocyst. Okay, this is very important. 6 weeks later, presents with epigastric pain, maybe epigastric uneasiness and something. You do imaging, you see a pseudocyst, it's a pseudocyst. Okay, we'll get to that later in detail. Okay. Tamam. Other complications you guys mentioned, it can, if you have recurrent bouts of acute pancreatitis, can lead to chronic pancreatitis. If you have a patient who has acute pancreatitis, they might have 2 very acute complications, which is, for example, DCIS, which is systemic shock and sepsis, and thrombosis. And then you have ARDS, okay, which is acute respiratory distress syndrome, okay? So these are the 2 more acute ones. So what does this patient have? Acute pancreatitis. Here you have hemorrhage with these white areas. You might see fat necrosis, which is this area over here with destruction of the acini and so on. It's acute pancreatitis, okay? How about this patient? Same patient, acute pancreatitis. However, you have air that's present around the pancreas. This is necrotizing pancreatitis. It's more severe, okay? That's basically that. Now, with patients with pancreatitis, something just to note is there is a criteria to assess the prognosis of pancreatitis and how severe it is, which is something called Ranson's criterion. The whole principle is you're assessing the patient when they're admitted and then 48 hours later to see if there's any changes that happens. When they were first admitted, it's usually, what do you check for? Age. If they're above the age of 55, it's associated with more severe outcomes, more worse outcomes, okay? So age over 55. WBC count. It obviously causes inflammation, systemic cytokine release, and so on. So it might be over 16,000, which is worse. Blood glucose over 200, serum LDH over 350. Serum LDH is indicative of necrosis, okay? So one of the signs of necrosis is severe elevation of LDH, okay? So that's why it's worse. Serum AST over 250 if there's hepatic involvement, and also there is one etiology, which is alcoholic hepatitis. If there's both of them, obviously it will be a worsening status of the patient. Then 48 hours, you'll see what changes happen with this patient. Did the hematocrit fall? Why? Because of hemorrhagic pancreatitis. It was their hemorrhage, okay? Then you have BUN, which if it rises more than 5, which indicates renal impairment. Arterial PO2 below 60. Why? Because of the ARDS. Okay, so you see, oh, did anything happen with their oxygenation? Serum calcium below 8. Now, pancreatitis causes hypocalcemia because of the fat necrosis. It uses up the calcium. So if you see the serum calcium below 8, it means that something's a change. It means there's severe fat necrosis that's happening. It's worse. Okay. Base deficit of more than 4. This is basically in the acid-base parameters. If there's a base deficit, low bicarb, more than 4, this is a worsening sign. And fluid sequestration more than 6,000. Do you need to remember this criteria? There was a message, I think. No criterias, okay? If anything, it's either this criteria or true love and wits criteria that comes, okay? From my opinion. Now, patient 6 weeks later presents with epigastric pain, has this sign. What do they have? 6 weeks later, most common complication of pancreatitis. Good, pseudocyst. تمام? Pseudocyst. This is the cyst over here. Now, why is it called pseudocyst? Does it have an epithelial lining? Yes or no? No, good. So that's why it's called a pseudocyst. It's fibrous granulation tissue walls with no epithelium. Okay. Now this cyst is filled with the pancreatic enzymes and secretions. So how do you manage this patient? What do you do to the cyst? Drain it. Good. Now there is a difference if the size difference, if it's less than 5 or more than 5, don't need to remember that. Okay, it was mentioned somewhere, but it's not important. Again, this patient, what do they have? Same thing, it's pancreatic pseudocyst. Again, not an epithelial lining, it's fibrous with granulation tissue. Okay. How about this patient? Chronic pancreatitis. Good. Okay, you see calcification and fibrosis. Chronic pancreatitis is due to what's the most common cause of chronic pancreatitis worldwide? Alcohol. Good. Second most common. Stones. Most common in children. Cystic fibrosis. Acute pancreatitis is trauma. Chronic is cystic fibrosis. So with chronic pancreatitis, it obstructs the pancreatic ducts or pancreatic acini, which will lead to decreased pancreatic enzymes and secretions that can go into the intestines. So they will present with pancreatic insufficiency. So what will happen to their stool? Let's take a step backwards so the concept is more clear. What nutrient can they no longer digest and absorb? Fats, good. So they have fat malabsorption, good. So they will have steatorrhea. Okay, good. Okay, and alongside what vitamins will be deficient? ADEK, good. So, which is the fat soluble vitamins, good. Now, okay, then it can extend into islets of Langerhans. So what can they present with? Diabetes, good. So management is you give them pancreatic enzymes, replacement. Okay, and you treat the diabetes. The most important thing in management as well is they might have pain, epigastric pain, so you relieve the pain. Surgery, if you want to do surgery, it's just to relieve the pain. Okay, that's it for chronic pancreatitis. Now, if you do ERCP, you can see a chain of lakes appearance, which is characteristic of pancreatitis, okay? Of chronic pancreatitis, which is basically the fibrosis causes strictures and then you have dilated portions, similar to primary sclerosing cholangitis that we saw, okay? This patient, chronic pancreatitis, same thing. Destruction of the whole pancreas, you have fibrosis, which is over here. Destruction of the acini, you might have dilated ducts, such as over here, and then this one is more clear. Dilated ducts, okay? Now, we're almost done. Pancreatic tumors and cancers. You have two benign ones, which is this one and another one. What is this one? Serous. Cyst adenoma. Okay, serous cyst adenoma. So from that, what type of secretion is it? Is it serous or mucinous? Serous, okay? Now, what type of cells are lining it? Cuboidal, good. Okay, where in the pancreas does it develop? Tail. Sorry, body, okay? In the body of the pancreas, okay? What tumor suppressor gene is associated with serous? Good, VHL. Remember that, okay? How about this patient? Mucinous. So what type of secretion? Mucin, okay? This is mucinous cystic neoplasia, okay? Or cyst neoplasms, okay? This is mucinous. What type of cells line it? Columnar. And what genes are associated with it? KRAS, RNF, okay, good. TP53, excellent, good. Where in the pancreas? Body and tail, good. These two, you will see again in endorepro. The same exact pathology. In fact, I believe this is an ovary. Okay? So yeah, you'll see this in the ovary again. Okay? So anyways. Now, pancreatic adenocarcinoma is a malignant version. Very poor prognosis. Usually as from the pancreatic duct, that's why it's called adeno. Okay, it's glandular. Very poor prognosis. It arises in the pancreatic head. And then very important is what tumor marker is associated with it. CA19-9. Okay. What tumor marker is associated with hepatocellular carcinoma? Alpha-fetoprotein. What tumor marker was associated with colorectal cancer? Tumor marker. CA. Carcinoembryonic antigen. Good. Okay. For the risk factors, it's some of the chronic pancreatitis, more than 20 years. Smoking is the strongest risk factor that causes pancreatic adenocarcinoma. You have obesity, BMI, diabetes, elderly age, and so on. What does it present with? Abdominal pain radiating in the back, weight loss because it's cancer. Most cancers, all cancers will cause cancer, cachexia, weight loss. Now you have two important signs. First one is obstructive jaundice with palpable non-tender gallbladder, which I said before, which is the Courvoisier sign. Why? It's because it's in the head of the pancreas. So it causes obstructive jaundice. Okay? Now, the other side is migratory thrombophlebitis, which is basically these red lesions that form that migrates. Okay? This is called the Trousseau syndrome. Okay? So, now, just like colorectal cancer, this has a sequence of mutation that it requires, which are the genes that you need to remember. So first it starts normal pancreas. Then it has pancreatic intraepithelial neoplasms, okay, neoplasia, which is 1A, 1B, 2, 3. Okay, it gets worse as it goes until it becomes invasive. What genes does it require? The first one is KRAS and telomere shortening. KRAS is important to remember. It requires an activation of P16, which is in intraepithelial neoplasia 2. And then in 3, inactivates P53, SMAD2, SMAD4, and BRCA2. Why is this important? Is there are certain tumor syndromes, such as BRCA2, which is important when we come to the breast later on. Pancreatic cancer can come with it. So BRCA2 mutation is associated with pancreatic adenocarcinoma and breast cancer, okay, when we get to the breast later on. So tumor syndrome is a risk factor for pancreatic adenocarcinoma. Okay. How do you manage patients with adenocarcinoma, pancreatic adenocarcinoma? Surgery. Remove it. Okay. What do you remove? The whole pancreas. Is that enough? Yes or no? No, exactly. So you do Whipples. Okay, exactly. Perfect. Whipples, you remove a lot of things. Okay, it's very, very, very severe procedure. Okay. You remove the entire pancreas, you remove a large portion of the duodenum, some of the biliary tree, you remove a large portion of the stomach. It's a very, very bad procedure. Okay. Has very, very poor prognosis as well. Okay. That's pancreatic adenocarcinoma. This is it on imaging. This is the tumor over here. Okay. Do you need to remember this image? I doubt it. Okay. Now, is this hard to diagnose? Yes. Why? It's because it's retroperitoneal. So you see here, there's a mass that's retroperitoneal. And then this image. What do you see on this image? This is pancreatic adenocarcinoma. Desmoplastic reaction, which is fibrosis. Okay. It's a highly invasive with fibrosis or desmoplastic reaction. تمام. And that's it for the pancreatic adenocarcinoma. Now, the neuroendocrine tumors. Okay. These neuroendocrine tumors will come from the islets of Langerhans. Okay. These are important to remember for Dr. Bassas's lecture. Okay. And I think this is the only thing you need to remember from his lecture, I believe, if I'm not wrong. Okay. Because there's highly overlap, and most of clinical is overlapping with the rest. Anyways, so you have these 5 main tumors that you need to remember. From these, this one is not too important, but we'll get to it. First one is insulinoma. From the name, what hormone does it secrete? Insulin. Good. So what cells of the islets secrete insulin? Beta cells. So it's a beta cell neoplasm. Okay. A lot of insulin causes what? What causes the glucose? Does it come low or high? Hypoglycemia. So insulinoma is associated with a triad called Whipple's triad. No. Multiple lymphoma, B cell, diffuse large B cell lymphoma. This is in the stomach. This is for H. pylori. Okay. Insulinoma causes something called a Whipple's triad. What is the Whipple's triad? Firstly, as we mentioned, is that high insulin causes low glucose. So it's all around the low glucose. So hypoglycemia, symptoms of hypoglycemia. That's number one. Is signs and symptoms of hypoglycemia. What does that present with? Lethargy, palpitation, severely can cause coma, syncope. Okay. These are signs of hypoglycemia. Other than that is evidence of hypoglycemia, which is lab. Okay, so you see, you do lab, and oh, okay, this patient has hypoglycemia, it's very low glucose, around low 60, okay? Very low levels of glucose, okay? You give them therapy for hypoglycemia, which is, for example, glucagon, or you give them candy or sugar, okay? This corrects it. All of their symptoms go away. This is the triad. This is the Whipple's triad. Okay, this is key for insulinoma. How do you diagnose insulinoma? Actually, you do imaging, which is going to be in the head of the pancreas, and you do something else, which is lab investigations as well. Other than glucose, you can check insulin levels with C-peptide, because this is something that's endogenous. This will be described to you in more detail in endocrine. But if you guys remember, when insulin is synthesized, it's insulin plus the C-peptide. Then it gets cleaved when it's in the vesicles, okay? So when it gets secreted, it's secreted in both amounts. It's equimolar. Insulin and C-peptide both together, okay? So C-peptide will be elevated with insulin elevated as well. Why is this important? If someone's taking injected insulin, if there's fastidious disorder, for example, only insulin will be up, C-peptide will be low. In insulinoma, very important, is both of them will be elevated, okay? Tamam. I'll talk about men 1 later, okay? Treatment is you remove the head of the pancreas tumor, which is insulinoma, okay? Tamam. The other cell tumor is glucagonoma. From the name, what hormone or what is secreted? Glucagon, okay? What type of cells secrete glucagon? Alpha cells, okay? Alpha cells secrete glucagon. Tamam. The most keywords to remember: hyperglycemia, which is diabetes, and very important, which will always be given to you in a case, is something called necrolytic migratory erythema. How do they describe it to you guys? I have these red spots that keep moving around. It goes away. One of them goes away from my left hand and it appears in my right leg. The right leg one goes away, it comes up in my right arm. This, with diabetes, hyperglycemia, is characteristic of glucagonoma. What will they have elevated? Glucagon. Remember these 2 features, please. Okay. Other signs is DVT, thrombosis, weight loss, depression, diarrhea. Okay, anyways. Treatment is something which is somatostatin analog. Remember in esophageal varices, we give this octreotide. Okay, octreotide inhibits everything in the GI. Okay, so you give octreotide for most of these tumors. Okay, and it inhibits everything. So you give octreotide or surgically resect it. Somatostatinoma is not too important to remember, but it comes from the pancreatic delta cells. You have a lot of somatostatin, so you have low amounts of everything, literally. Okay, so you might have diabetes, gallstone, which is acalculous because of low amount of cholecystokinin, stasis of bile, achlorhydria, because it inhibits gastrin, which will decrease the amount of acid production, steatorrhea, because it decreases pancreatic secretions, a lot of things, okay? Usually treatment is resection. Then these 2. Zollinger-Ellison syndrome, another name, is gastrinoma. So gastrinoma is because of gastrin production, okay? Usually it's in the pancreas or the duodenum. Key things about the gastrinoma is it's multiple ulcers, peptic ulcers, in the duodenum, goes all the way to the jejunum. This is characteristic of it, okay? Multiple ulcers, okay? Why does it cause multiple ulcers? Gastrin will increase acid production, okay? We've talked about this in the first session. Now, there's something called positive secretin test, not too important for you guys to remember, okay? Now, there's another thing, which is VIPoma, vasoactive intestinal polypeptide oma, okay? VIPoma. VIPoma, it causes diarrhea. We talked about this in micro in the last session, okay? It increases the amount of intestinal water secretion and electrolyte secretions, okay? So what will this cause? Watery diarrhea. Because of the electrolyte shifting and the electrolyte loss, you'll have hypokalemia. And then VIP also will inhibit the acid secretion, so you have achlorhydria. This is what we call WADHA syndrome: watery diarrhea, hypokalemia, and achlorhydria. Okay? All of these tumors are associated with a syndrome called MEN1 syndrome. MEN1 syndrome is multiple endocrine neoplasia syndrome. Okay? This is more important when next block. Tamam? But for me to explain very quickly, again, it's not too important to remember. Multiple endocrine neoplasia, there's 3 types: MEN1, MEN2A, MEN2B. MEN1 will have the pancreatic tumor. Okay? MEN2A and MEN2B does not. That's the thing you need to remember about it. So in MEN1, what do they have is pancreatic tumor. The most common one associated with MEN1 is this one, insulinoma. Okay? What other manifestations do they have in MEN1 syndrome? It's 2 other things. Pituitary adenoma, so they might have prolactinoma. How does it present with bitemporal hemianopia, headaches, and in females typically is galactorrhea, which is milk secretion from the nipples. Okay. The other manifestation is parathyroid adenoma, good, which is hypercalcemia. Tamam. MEN2A will and MEN2B will not have pancreatic neuroendocrine tumors. Instead, both MEN2A and MEN2B will have thyroid cancer, which is typically medullary thyroid cancer. Again, you'll take this in the next block. And pheochromocytoma in the adrenal medulla. MEN2A will have parathyroid hyperplasia. MEN2B will have mucosal neuromas. I don't think you need to know this at your level in this block. Next block is very important, and in my future OSPE review, inshallah, we'll cover this in detail. Tamam? To test you guys, because I need you guys to know this, if someone has hyperglycemia and has moving erythematous spots, what do they have? Glucagonoma. If someone has multiple ulcers in the duodenum and the jejunum, what do they have? Zollinger Ellison or gastronoma. Good. If someone has a palpitation, confusion, coma, signs of hypoglycemia, insulinoma. Good. If someone has watery diarrhea, hypokalemia, and achlorhydria, VIPoma. If someone has low glucose, hypercalcemia, and headaches, what do they have? With bitemporal hemianopia. Insulinoma with MEN1. Good. Okay. That's all you need to know for this lecture. Okay. Now, very quickly, is to these 2 slides. These 2 are something worth mentioning, and this is basically concludes the entire crash course. First one is this patient with GI obstruction. What do they have? This is important in radiology. You might get a question on this. Firstly, they have evidence of GI obstruction. Key thing is just look over here. Paraumbilical hernia. Good. Just memorize this picture. Okay. The last slides in the hepatobiliary imaging has quiz. Okay. Know every single image in that. And we've covered all of them in this crash course, in the entire 3-part crash course. Okay. Last thing is know which structures is retroperitoneal, which is this mnemonic, which is sad pucker. Adrenal glands, aorta, IVC, duodenum, majority of it. The most important is the pancreas that you need to remember. We got a question on it last year. Okay. Then you have ureters, colon, kidney, colon, some of it descending and ascending. Transverse is intraperitoneal, and kidneys, esophagus, and rectum. Okay. Know these retroperitoneal organs. Just have them in mind. Okay. Have this mnemonic in mind when you go into the exam. Specifically, know the pancreas. Okay. Do you guys have any questions? And this concludes the entire crash course. Any questions of any part of this crash course? Yeah, sure. Okay. Okay. So oropharyngeal dysphagia, when you have a patient with oropharyngeal, it's the same. Yes. So oropharyngeal dysphagia, first thing is clinical signs and symptoms of other diseases. So either they have a stroke or myopathy or something, okay, that causes oropharyngeal dysphagia. To evaluate the dysphagia, it's video fluoroscopy, which is the same as the modified barium. What's the difference between, so the difference between them is in video fluoroscopy, it will show you the entire swallowing stages. So it will show you the bolus going from the mouth to the pharynx to the upper esophagus and so on. This is important because in oropharyngeal, this might be a swallowing defect. So you want to see that. That's why we call it video fluoroscopy. Okay? That's why oropharyngeal dysphagia, you need to do video fluoroscopy because you need to see all the steps of swallowing. Okay? Which one is correct from that? From Yeah, okay. So yeah, that's why. It's your you do video from because you need to see the entire swallowing reflex. Like the entire stages of swallowing because it's usually swallowing defect. Okay. Ignore that. But it's video fluoroscopy. Why is it? Yeah. Okay. Anyways, any other questions, guys? Okay, three mechanisms lactulose. Number one is it converts ammonia, which is what's causing the encephalopathy, to ammonium in the GI, okay, which can be excreted. Number one. Number two is it inhibits the bacterial function. It kills bacteria, okay? It's bactericidal. So what does that do? Is it decreases the amount of metabolism of nutrients and so on in the GI that causes ammonia production, okay? Mostly protein breakdown in the GI, okay? That causes the ammonia buildup. So it reduces that. That's number two. Number three is it increases GI movement, okay? And this washes out basically the ammonia from the GI. These are the three mechanisms of lactulose. Okay. Yes. What's the other question? Do they have previous history of GERD? If their neuro symptoms are like stroke or something and clear signs of oropharyngeal, I'd do video fluoroscopy. Okay, the patient is very old. It's more likely to be that. If they have smoking history, clear evidence of uh, esophageal dysphagia. I don't know then. If it's incomplete, then but I would do video fluoroscopy, and I think it's what I went for. And I did go for. I remember that question actually. I went for video fluoroscopy, and I believe it was correct. Um. So yeah, it's an 8-year-old adult, like very elderly patient who has signs of a stroke. Yeah, yeah. So I would go for video fluoroscopy. Anything else, guys?
Anytime. Yalla, best of luck to you all. Inshallah, this exam goes very well. I hope this crash course was helpful and beneficial. If you guys have any questions in the next few days that you guys have, please feel free to message me. And yalla, best of luck.